The Acting Vice Chancellor, Professor A.O. Loto, the Deputy Vice Chancellor, Professor Rosangela Muba, all other principal officers yet to be present, the Chief Medical Director, Unimed Teaching Hospital, permanent secretaries, and other government dignitaries here present, the keynote speaker, all panelists, all deans here present, directors, professors, heads of departments, all our invited guests, staff of the University of Medical Sciences and Unimed Teaching Hospital here present, students of University of Medical Sciences here present, and gentlemen. It is a tremendous honor and privilege to welcome you all to the 4th Grand Round of the School of Public Health, University of Medical Sciences. This is an annual scientific event, Unimed School of Public Health, where emerging issues in the field of public health are discussed. The event usually attracts public health professionals and dignitaries within and outside Ondo State. In order to ensure diversity, the different departments in the School of Public Health have taken turns to host this event over the years, which took place on the 17th of March 2021 by Department of Epidemiology and Biostatistics, and was titled COVID-19 Research Agenda. On the 30th of November 2022, the Department of Environmental and Occupational Health hosted the second edition, and the theme was Climate Change, Health and Environment. The third edition was subsequently hosted by the Department of Health Promotion and Behavioral Sciences on the 31st of July 2024 with a theme, Preventing the Next Pandemic, the Use of Artificial Intelligence. This year's edition, which is happening today, is the 4th in the series and by the Department of Health Policy and Management. The main theme is health systems strengthening, building resilience for the future at WHO Ondo State Office is on ground to do justice to the topic. The two sub-themes, implication on seasoned experts from within and outside Ondo City, have been carefully selected as panelists and will be discussing these topics during the panel discussion sessions. The event also has poster exhibitions, and everyone is encouraged to engage with the poster presenters during the time allotted for this. This year's special, the first attendance at the Unimed School of Public Health Grand Rounds, and is happening during Public Health Grand Rounds, and is happening during my tenure as the acting day round up my 1 year as the acting day round up my 1 year period of sabbatical leave in the University of Medical Sciences, Ondo City. The Acting Vice Chancellor, Professor A.O. Loto, and sincerely appreciate him for gracing this occasion. It is a great delight for me to also welcome the Deputy Vice Chancellor, who I think is the only principal officer here present other than the Acting Vice Chancellor. I also welcome other than the Acting Vice Chancellor. I also welcome every other distinguished. I want to specially appreciate, ably led by Dr. Victoria Oladoyin, for putting together this remarkable event. My appreciation also goes to all members of School of Public Health who have assisted in different ways to make this event a success. I must confess that I am indeed privileged to lead a team of very dedicated academic and non-academic staff. The Grandround indeed promises to be very interesting, and I encourage all the participants to stay to the end. Once again, you are all warmly welcome. Thank you very much.
Please a round of applause for the Dean one more time. Ladies and gentlemen, I recognize also in our midst this morning the University Library, Dr. Biliamin Ubola. Please a round of applause for him. I missed out someone who is also very crucial to this person of the local organizing committee, Dr. Victoria Oladoyin, and all other members of the local organizing committee. Please a round of applause for them. And while recognizing those that we missed out, the CMD also came in, the Chief Medical Director, UNIMED TH, University of Medical Sciences, Teaching Hospital, Bala. Also, okay, please a round of applause for him. You are welcome, sir. And maybe I should say this, so that as you register it on your mind before leaving, I will be taking that your suit after today's event. Is dope. You are welcome this morning. Quickly, we move to, if you check the program, so it may not follow the order that you have. Right now, we want to take few. I mentioned something at the beginning, that in this hall, there are policy makers, there are scholars, and they have told us they also have messages from their different organizations for us. And I want to call on the representative of the special advisor to the representative of the special advisor to the governor to give his goodwill message. Please a round of applause for Dr. Oyeneyin, representing
the Acting Vice Chancellor, Professor A.O. Loto, Deputy Vice Chancellor, Professor Rose Angela Wuba, all principal officers here present. I recognize the Acting Dean, School of Public Health, Professor Johnson, the CMD UNIMED Teaching Hospital, distinguished professors and faculty members, the keynote speaker, all distinguished panelists, permanent secretaries and all invited guests, all staff and students of this great institution, distinguished ladies and gentlemen. From the Special Advisor on Health, Professor Michael Odimayo, who would have loved to be here, but he has asked me to represent him. He sends his apologies. I'm delighted to be in another milestone, which is the 4th annual Public Health Grandround with the theme, Strengthening. The current administration, under the able leadership of His Excellency, Dr. Lucky Orimiso Ayedatiwa, the 7-point developmental agenda, our E's. As we all know that E stands for effective healthcare and socioeconomic well-being of the people of the Sunshine State. And this is very key, a key pillar of the agenda of his administration. The state government is very committed to this institution and shall continue to support the university and work assiduously to ensure that the government build the health sector that we all be very proud of. I congratulate the acting Vice Chancellor, the acting Dean School of Public Health, the host department, the Department of Health Policy and Management, and also very important, the LOC members for putting together this very great event. I wish everyone a happy deliberation. Thank you so much, and God bless you all.
One thing I like about people representing those in the corridors of power is that they always make their promises in a tactful manner. But we appreciate the fact that the governor is committed to this university. Of all the things you said, I picked that one because we need your commitment for us to continue to do well. Thank you very much. Distinguished ladies and gentlemen, quickly we also take goodwill message from the Chief Medical Director of University of Medical Sciences Teaching Hospital. He looked up the moment I mentioned that. Probably something I know about him, in all the events we've attended together, he will always deliver, and this won't be an exception. Please let's put our hands together for Dr. Michael Bala. And do it very well.
Good morning, ladies and gentlemen. Our acting Vice Chancellor, all the principal officers of the university, all our leaders, professors, everybody in attendance. Like you said, I'm being put on the spot, but notwithstanding, we are here for an event that should make us proud. To have the 4th edition, it shows a lot of effort and sacrifices and painstaking contributions by everybody who has been involved. I look up to a very fruitful deliberations, and I want to wish all the organizers success, and all of us who are partakers today. Please, your attention is much needed. Once again, please tribute and be part, meaningful contribution of this event. Thank you.
Thank you very much. Please a round of applause for him. He did it according to the shortest verse in the Bible. Straightforward, and he has encouraged us to participate robustly when the time for discussion comes. Thank you, sir. Also, I want to bring to this side Mr. Olamide Ayedun. Not here yet. A permanent secretary, Ministry of Finance, is representative. Oh, okay. So I bring the representative of the permanent secretary. He's even here. You are confusing me now because I've introduced him earlier. Please let's put our hands together for the PS, Ministry of Finance, as it gives us 1/22 goodwill message.
As much as I want to stand on the already established protocols, I cannot but appreciate and congratulate the acting Vice Chancellor of this great institution, Professor Lotto, all the principal officers, guests, and students. I bring greetings from the state government. The DG, who is my friend of Dr. Oyenenyi, has said what is expected from government. I just want to add that government will not shy away from doing the necessary things. The responsibility of government towards the health sector, the government has been doing its best on this note. But yeah, I just want to add that there is need for us to be proactive and do what is expected of us. It has been mentioned that the health sector takes a priority in our EASE agenda. It's part of government program and priority, but there is need for the players in the health sector to do the needful, follow the due process, and, get necessary approval, and funds will be released as appropriate. But let me also encourage all of us, since we are here, let us put our mind at whatever will be discussed here so that we can have something to take home. Let me congratulate the School of Public Health for this feat. This is the 4th edition of the Public Health Grandround, and I want to congratulate the acting head of the acting dean of the School of Health Sciences, and congratulate the University of Medical Sciences. And I pray that at the end of this program, all of us, we must feel fulfilled, having participated in the discussion and all the rest of it. So thank you very much. God bless you all.
Thank you very much, sir. With that, we've come to the end of taking goodwill messages. And the time that is very crucial for us to go ahead with this program is here with us. Sometimes in March 2025, I visited the dental clinic for the first time in my life. Originally, I wanted to treat myself on my own, but the thing kept getting complicated until I approached Professor Adebayo, who told me that you are 4 people, go there and go and take care of yourself. Different experience completely about just one sector of the health system. Even though they removed 2 of my teeth, but I became much better. And my interaction with them also opened my eyes to what they were prompt, and the way, even when they asked me to come back for you, I felt I was okay, and indeed I am okay up till now. They did a very good job. But what is the point I'm trying to make? Until you interact with people, you may not know what you have been missing. And from that moment on, I have a lot of respect for dentists. Dentists do a whole lot of things within the health system. And when you now move around, the carefulness, to remove something is not easy. And I said dentists are superb. So when they gave us acting vice chancellor, and I discovered that the acting vice chancellor is not just a dentist, but a professor of dentistry, I said, oh, then we are in for something. This man also should be meticulous about what he does. The interesting thing I found out about him also, why some people went to school through incomplete metamorphosis, his own has been through complete metamorphosis. First studying physical and health education, having done that, now coming back also to the health sector, the mainstream. And I told myself, this man has done something. It is complete, moving around. Yesterday, he challenged some of us. He was doing some exercises. None of us could do what he was doing, even at almost 70. Distinguished ladies and gentlemen, I want to respectfully bring to this side of the divide an erudite scholar, a professor of dentistry, the one God has graciously picked at this point in time to paddle the affairs of the University of Medical Sciences, Ondo, the pride of Ondo State, the envy of other universities in Nigeria. Please, let's put our hands together as I bring to this side of the divide Professor Adolphus Odogun Loto.
Thank you. Good morning, everyone. I don't know protocol, and I don't want to have a protocol somersault. So I would like to flow with the established protocol by the previous speakers. And I would like to join them to express my thanks to everyone who is present here today for this grand round. For every human being, there is a purpose. And there is a purpose why we are here today. We are not here aimlessly. And there is a purpose for this grand round. Unlike any other grand round. What is the purpose for a particular grand round like the one that we're having today? It is to facilitate interaction amongst scholars, researchers, in terms of professional development, personal development, clinical education, and interdisciplinary collaboration among the various sectors of the health system. Now, if you look at the theme, health system strengthening, building resilience for the future. What is a system? A system is that which has input and output. And in between the input and output, you have many structures that interconnected and interrelated. And all these units must function together to produce the desired results that you are expecting or outcome. If there is any problem with any of the basic units between the input and output, then the system cannot deliver the right outcome that you are expecting. But you must also understand that everything under the heaven is always one or the other. And that's why they are talking about health system strengthening, building resilience, ability of a structure to withstand pressure, meaning excessive pressure without caving in or without being ruptured or without being destroyed. Then our health system so that can be resilient to be able to withstand pressure over a given period of time without being ruptured. And definitely we know in Nigeria, our health system is under the other. And we must find a way of building that resilience so that If the system breaks down, then it means we are in for it. So, I want us to really discuss this issue, how we can help the system to be able to withstand pressure of not having enough, financial pressure, human resource pressure, all the pressures that we can mention negatively, our health to go. This is where we have. For me, I will remain Nigerian forever. My identity, if you are in UK and you say you take probably their passports, you are now thinking that you are a citizen of UK, you are a liar. Because wherever you belong, you know yourself. You are only carrying the passport. Even the passport can be taken away from you at any time. So I'm a Nigerian, So you may think Nigeria is not good, but it's the best place to live. Prosbun Umba, I know you have traveled far and wide, and I've traveled far and wide too. I know from experience that home is home. But one thing that I like about Nigerians is that Nigerians can withstand pressure. And I believe you will learn a lot from this. And that is what is keeping us on. Because there was a study that was done, I was in Saudi Arabia, they said the happy earth, they come to the conclusion that Nigerians, even under whatever pressure, they are happy. On this note, I would like to declare this Grandround open.
I go now road, things say I don't know road. Every me mom, nine they move me, they lead me, they go. On God, mine is made up. Of course, no going back. Non-stop, on 240. Here she gone, hold on me to road. I'm steady, revving, Monte throttle. Got eyes on the prize.
All right, thank you very much. Welcome back from the short break in transmission. The short break wasn't due to any power outage. It was because we needed to take some photographs. Distinguished ladies and gentlemen, what we are supposed to be taking right now is the keynote address. But the information reaching me is that the keynoter is in a meeting with the executive governor of the state, and I will join us. Right now, what we'll do is to take some critical issues that we have. We are supposed to have two panel discussions, first and the second one. And with the permission of the organizers, we'll be taking the second one first, whose focus is on human resource gaps in healthcare, the ticking time bomb. That is what we'll be looking at. Without any iota of doubt, we all know that's a big challenge in our country at the moment. Gaps in human resource, in healthcare. And we have erudite scholars, policy makers, people who have seen it all in this sector here with us to discuss this issue so that we can collectively find a way around it. How do we solve this challenge? What do we need to do? And for this particular panel discussion, I would like to invite the moderator for the session, Professor Amoron. Is Professor Amoron here? Second one? Okay, I learned Dr. Adeshion will be moderating the second one. Dr. Adeshion is an erudite scholar in public health, and I'm sure our coordination of this session will be very, very interesting. Ladies and gentlemen, Please a round of applause for Dr. Adesina.
Thank you very much. I welcome all of us to this occasion, and I would like to stand on the existing protocol. So I would like to call on the panelists for this discussion. Mrs. Mary Aliu. Please, a round of applause for her. The next is Mrs. Margaret Oladipo, Deputy Director of Nursing, and Professor E.T. Adebayo, University of Medical Sciences, Ondo. Erudite scholars who are critical stakeholders in human resource when we talk about healthcare training, healthcare professionals. Topic, human resource gap in healthcare, the tickling time bomb. A round of applause for all of them once again. Thank you very much. I welcome everyone once and for all. I welcome everyone. Pass the mic for them to, in case I made a mistake in my introduction, as it ought to be done. So we can start from my immediate right.
Thank you so much. I am Mary Aliu, Director of Nursing Services from State Ministry of Health. Thank you.
Good morning, everyone. I'm Dr. Adetumi Shublade. I'm a consultant epidemiologist and biostatistician with Federal Medical Center. Thank you.
Good morning, everyone. I'm Dr. Paulinus Kunle Omode, the Director of Medical Services, Ondo State Primary Health Care Development Agency, representing the Permanent Secretary, Dr. Francis Adigoke Akonbiemu.
Good morning. I'm Adilo Joaku Ward. I'm CA Permanent Secretary of Hospital Management Board. Thank you very much.
I'm Dr. Bala Michael, the Chief Medical Director of Unimed Teaching Hospital. I'm also a consultant obstetrician and gynecologist. Thank you.
Good morning, everyone. I'm Oladipo Margaret Adekola, Deputy Director of Nursing, Primary Healthcare Tutor from Ondo State College of Health Technology, Akure.
I'm Professor Dean, Faculty of Dental Sciences. I'm sure I came in here because in the health sector. Thank you.
Yes, thank you, everyone. So we'd like to pick we'll be discussing is human resource gap in healthcare, the tickling time bomb. We all know what is currently happening with this JAPA, that is happening in the health sector. So quickly, I would like to start with Professor E.T. Adebayo, of healthcare personnel. The university is a critical, skilled health worker. So I would like to ask, what are the human resource challenges in Nigeria, and how can the university contribute to reversing the decline in trained health professionals? Prof.
Thank you. The acting Vice Chancellor has spoken about the fact that the healthcare system, the healthcare service is composed of the workforce, the health information system, medicines and technologies, financing, leadership and governance. Now, what that shows us is that the human resources for health only constitutes one part of the healthcare delivery system. But we are all aware that our population in Nigeria and in many other developing countries is increasing, and our human resources for health are not matching that increase in population. For those in the public health sector, you also know that we are living longer. And because we are living longer, it also means that we also need healthcare services for a longer period than we were maybe
30, 40 years ago. I've asked people that 40 years ago, we used to have all these abikus and shigidis in our villages. You will observe that those things are no longer very common. And it's not because people don't want them, but because they are no longer relevant because of improvements in the health system. However, our healthcare system, especially our human resources for health, is under severe challenge. The challenge is worldwide, but it is worse in low to middle income countries. And I think yesterday, the registrar of the National Postgraduate Medical College, it was reported in the dailies this morning, that about 50,000 residents have left the residency program. The WHO stipulates that we should have 1 doctor to 600 people in our population. Nigeria has 1 doctor to 9,000 patients. The WHO says we should have 1 dentist to 10,000 people in the population. Nigeria has about 1 to 34,000 to work with, living conditions, low quality of life. Majority of our people who live in the rural areas lack even access to basic healthcare services. Our human resources for health is skewed in favor of urban areas. We have issues of number, we have issues of mix. That is, we have issues that we don't have enough number. Then we also have issues of the caliber of healthcare staff that we turn out. In our rural areas, they have challenges of lack of infrastructure. At one time, our primary healthcare centers were not places that anybody wants to go to. And so many people flood the teaching hospitals, even for very minor ailments that that can be taken care of close by. People don't want to serve in the rural areas because of limited infrastructure. That is, no lights, no water. You don't have schools for your children. Opportunities to improve your career are not there. Then the human resources that are even available, some of them, their attitude to the patient will make the patients not want to come back. Absenteeism. Some of them have private shops that they divert patients to, or they make sure that the public health facilities don't work so that their private shops will work. And then unfavorable employment policies. So, having chronicled all our problems, what are our solutions? Part of the vision behind the establishment of the University of Medical Sciences is so that the University of Medical Sciences will contribute to provide solutions to our human resources for health. Within the 10 years of the existence of this university has unarguably the highest number of health professional courses being run in any university in Nigeria. In the aspect of dentistry, where I'm acting dean, our university is the only university that is training dental surgeons, dental technologists, and dental therapists at degree level in West Africa. In medical rehabilitation, we have degree programs in prosthetics and orthotics, occupational therapy, speech and language, audiology, which is the highest mix of medical rehabilitation professionals you can find anywhere. And that goes on for various other professions. So we are contributing towards increasing the number. We are also contributing towards improving skills. For example, some programs in Nigeria had hitherto only existed at HND level. That has stagnated the career options for this category of professionals. For example, prosthetics and orthotics in Nigeria was only being taken at the grade level only at the Federal University of Technology, Owerri. And even then, it was not well known. Most of the graduates were HND people. And that meant that they were stagnated in terms of career prospects, they were stagnated in terms of skill sets, they were stagnated in terms of how they could further their education. They were also stagnated in terms of fulfillment in their job specifications. Now, the University of Medical Sciences introduced conversion programs in which some of these HND graduates put them, and that increases the skills they have. It also increases their job satisfaction, and it also enables them to be able to further their education elsewhere, which will further deepen the capacity of those professionals.
And Prof, please, I would like to come in here, and in just 30 seconds, I would like you to round up your session by telling us, you have chronicled what UNIMED has done in increasing enrollments, and also making sure that we have a lot of healthcare programs being happening across other universities in Nigeria.
About 2 months ago, the federal government, through the Federal Ministry of Education and Tetfund, selected 18 universities for a 4 billion naira grant to double intake into medicine, then pharmacy. And that is meant to improve infrastructure, double their capacity. The federal government is also funding centers, simulation laboratories, building of hostels, and equipping various universities to be able to increase their capacity, both in terms of the number and in terms of the skills that are available. I think going forward that the university will have to look at is the issue of aligning all these various professionals that the university is training to work together in an environment where there is mutual respect, mutual understanding, so that there is better appreciation of the roles of each of these people during training, which will now serve them well when they go outside. That is something that we are thinking about in some of our primary health centers in order to foster collaboration.
All right, thank you, Prof. That you ended with a point that we're still going to discuss later on. I would like to also mention as we go forward that there will be room for question and answer. Giving their talk, please, we can be noting down our questions so that when that time comes, we can come up with it. Okay, so I would like to go next to the Director of Nursing Services. As we all know that nurses, they are also critical stakeholders, and their services is also central to the effective functioning of any healthcare system. So I would like to ask, what are the current challenges facing the nursing workforce in Ondo State, and how is the ministry addressing issues of burnout and attrition? And I'll be glad if you can make this in 2 minutes.
2 minutes. Good morning, everybody. Like he has rightly said, nursing is very critical to health sector. We are the pillar that all other health workers lean on. And before COVID-19, I could still remember, at FMC Owo, we have well over 700 nurses. But as I speak now, we have 400 of them. At HMB level, which covers all the secondary health facilities in the state, before COVID-19, we have about 1,500 nurses working in all our secondary health facilities. But as I speak now, we have only 651. You can see the gap on and on like that. And the few that are remaining, they are burnout. And that's why we need to encourage them, as we used to, that any forum I find myself, we need to encourage them because they still have the love of Nigeria. That's why they are still staying. Though some of them are still planning underneath to Japa. But be as it may, we need to encourage them. And you know that when there is burnout, it's stress emotionally, psychologically. And when you talk of this attrition, like we have said, that is a ticking time bomb. If something is not done with immediate effect, the health system in the state and in Nigeria would be another thing that we're talking about. Because these people that are working, we need to do what? To do more in encouraging them. And as ministry, we have policies on grant, on recruitment of nurses. I could still remember some of the people that were recruited, even at the civil service, some of them have run away. At HMB, they also did their recruitment last year. Some has left. So be it as may, the ministry at one point or the other is looking for more collaboration. And those people that are remaining, because even when you talk of Japa, there are some people that Japa from Ondo State to Lagos State, Japa from Ondo State to Ekiti State for better payment or pay. So the government needs to do or look at areas. And like I used to tell people, not everything that is monetary. We could see that some are not even motivated. And motivation can be in form of thank you, giving of a plug, supporting them. And one thing, another thing that we are looking critically, like I did monitoring about 2 weeks ago when I came back, I think I told my PS that some of our facilities need to be worked upon, beautify them. Because when you are going to a facility, if the environment is not fanciful, it's not encouraging, people will run away. Most especially our primary health care facilities. When people see that the environment is encouraging, they will come. And another thing that we need to do, that we are still working on, that is still germane, is the attitude. You see people that are coming to the profession, some of them are coming because of the money. I could still remember when we entered into nursing, we enter with passion. We never knew that the nurses and the money of a healthcare worker is even far more ahead of the others. We were there because we have passion to take care of people. So if that passion can still come back, because you can see them, some of them, they have nonchalant attitude to their job. But on our own, monitoring and evaluation, we are doing it at the ministry level and we'll still continue to do it. Thank you.
Thank you very much, Ma. So I would like to move to Mrs. Margaret Oladipo, the Deputy Director of Nursing, Primary Health Care Tutors, because you are also one of those people producing the frontliners when it comes to the healthcare system. So what are the current gaps in training capacity for frontline primary healthcare health workers, and how can institutions like the School of Health Technology be strengthened to meet the demand?
Thank you very much, Ma. Good morning once again, everyone. By the grace of God, Ondo State College of Health Technology, our mission and vision is to train the middle level manpower for health. And this we have done, well over a decade. By the grace of God, I happen to be one of their students in those days. And when we talk about primary health care, we are talking about frontline health workers, like you have rightly said, Ma. And they are the people that, majority of the time, in Nigeria, and especially in Ondo State, they are the first point of call. They are the first set of people that you see, the sick people, pregnant women, they want to meet at the various health facilities. But despite the fact that they are always there, you see them that they are unsupported, they are undertrained, and they are overburdened. Now the current gaps. We have workforce shortages. We have talked about it severally, and we're still going to talk about it. The JAPA syndrome is also affecting the college. Some of us tutors have left. The pulling and the pushing factors have made them to leave. Then there's high attrition due to poor working conditions, low pay, and lack of career progression. People want to go and update their knowledge and skills so that you can better facilitate teaching and learning. But at times we'll be told there's no vacancy. You are not, that will make you to go for that program. And then we have inadequate training infrastructure, very, very important. If you come to the Ondo State College of Health Technology now, we don't have a single lecture theater. You know, when we come to this university, we know it's a university, but by the grace of God, when my Oga, the DNS, Ministry of Health, has said, when you go to an institution, you know, when you get the aura that you have on getting there, will even make you to want to come. And that's why you see, you know, we have limited training, you know, institutions that are public owned. And the very few that, like in Ondo State now, we are the only, Ondo State College of Health Technology is the only College of Health Technology that is being owned by the government. Outdated, come and see our demonstration, you know, rooms, you know, no equipment, no classroom. At times students have to leave, you know, there are some departments, as you are teaching your students in one department, another department is coming, they want to come and receive their own lecture. So we have, you know, inadequate lecture, you know, lecture room, classroom, inadequate teaching, you know, infrastructures, and at times this one is really affecting our accreditation, you know, because when you don't have all those facilities on ground, the different training boards will not. How are we managing this?
Addressing these issues.
By the grace of God, we are coping, and you know, that's one thing. That's the major gap and the major challenge between the public, you know, institution and the private-owned institution. We have the issue, you cannot spend money, even when you have your IGR, you have to write protocols up and down. But by the grace of God, we are coping, you know. We are trying our best, you know. Habibu, our provost now, that has been doing his best, you know. He's trying to go through intersectoral collaboration, you know, philanthropists, you know, and help us. People, you know, come and is trying as much as possible to, and this one we have been doing. Like the time that we had the performance-based governor administration, there's a way it affects the pre-service training, you know, for when they want to have them. Our students will be invited, you know, our students will be sponsored. Some of us will have to go on training based on that. Some of these MCPDPs that at times we may not even be able to go have been of help. Thank you very much.
Thank you very much, ma'am. Yes. Takers, that is when the universities, the institutions produce these health workers, the uptakers are the hospitals, the medical care centers. So I would like to go to Dr. M. Ogbala, the Chief Medical Director. Unimeti H is also a very important stakeholder in the treatment and care of health of humans in Ondo State. So I would like to ask that how is Unimeti H coping with increasing workload due to this human resource for health cadres?
Well, thank you. I want to appreciate the previous speakers because they've made beautiful presentations about the challenge in Nigeria. They couldn't have painted the picture better than that. But from the practical point of view, I want to add one or two things to what they have said. There's hardly a day I don't have resignation letter on my table. Sometimes you go to the offices, the table will be as high. You want to think you do serious business, only for you to flip through, only to start seeing people resigning. And that's the reality. But it's not about the challenge. People will resign because there are different reasons why people resign. It's not only about finance. It's not only about the job opportunities. There are those who resign because of security issues. If I was attacked in his house, from that moment he made up his mind he's leaving the country. So even if you pay millions, he's not going to stay because he couldn't sleep for one day, being killed by just weak scars. So there are several reasons why people
move. But those are challenges which other speakers have spoken about. What we've done, challenge these various issues and mount responses towards them. And I must say to us this morning that we are seeing very, very positive results. The three things, in my view, are very, very important. I boldly say, in the last 1 year, the government has been so supportive that they have the benchmark for the hospital 3 times in the last 1 year. Sometimes April last year, the government increased salaries April last year, October last year, and January this year. And that effort is to make sure the staff are well remunerated. We made that case. We are losing staff. Apart from there is what I would call local JAPA or internal JAPA, where people go to neighboring states. So we've been able to address that, and I can tell you for today that the salary scale being adopted in the teaching hospital is the federal salary scale, and that has taken away the issue of the luring to federal services. We're even going further. We have made cases that we must earn more than the federal, even if it's by 5%, such that salary will not be a reason why somebody would think between either working in the state or working in the federal. And from the resources we're getting, in few weeks, in few months, I'm sure we'll get there. I take a case of like house officer. The Unimed Teaching Hospital is the second highest paying hospital in the entire country. House officer, yes. House officer, yes. Second highest paying, you can go to confirm that. That's why there was a time in the entire 3 complexes, I mean Akure, this village, and that in town, that we had just 2 house officers in this entire 3 hospitals. But as at today, we have about 90 house officers. So, I think that deserves a clap. That's not, it's not a joke. It didn't happen by chance. It didn't happen by chance. It was a careful, deliberate, intentional decisions that brought that paradigm shift that we're beginning to ask ourselves now, the number of house officers. Now we have house officers on the queue. That is the truth. We have applications that say, no, we don't need this number now, because we took that action. Now you can fact check what I've said. House officers, they are all over the place, they can hack. Ondo State, Unimed Teaching Hospital pay the highest when it comes to house officers. And we're putting a lot in place to see how we can replicate that also for the residents and other people. The other thing we've done in trying to address the challenge is the introduction of task shifting and sharing. Because it's obvious now that it's obvious to us that even if you increase the salary, increment in salary alone does not translate to getting the health workers, because almost every place is trying to hold on to the staff that they have. We have looked at our workload. Some of these things can be delegated to other people. In our teaching hospital now, we've looked at areas where tasks can be shifted, and we're doing that effectively. For example, let me be a bit more specific.
Sorry, Prof, I'm sorry to cut you, because that's the next aspect we will call you to shed more light on. So I would like, please, let's appreciate Dr. Bala. It's very heartwarming to know that Ondo State Unimed Teaching Hospital is the second when you talk about payments of us officers.
Oh,
please,
yes.
Another round of applause for him, please. So I would like to go to Dr. A.O. Adiji, the Permanent Secretary, Hospital Management Board, Ondo State, because we know that you are part of, when it comes to making policies and also coordination of some of these activities. So I would like to ask that what strategic measures is the Hospital Management Board implementing to address the shortage and uneven distribution of health professionals across secondary healthcare facilities in Ondo State? Because we've heard about this JAPA syndrome has left gaps in different sectors and has led to unequal distribution of healthcare workers. So we would like you to give us your insights on the strategic measures the Hospital Management Board is implementing to address the shortage and uneven distribution.
Thank you very much. And my acting Vice Chancellor in absentia, I'm a Deputy Vice Chancellor. I'm a congratulate you on the newest Medical Director, Chief Medical Director of Unimed, Dr. Mark Egbala, and all of us here. Thank you very much. When I introduce myself, I say I'm from Ward 4. I could go southwest in Oka. We are here today now. If we ask you, what is your ward level? You don't know. And the majority of you don't know where they are from. And that is where it begins. We are not talking about shortage in Ondo City. We are talking about the ward levels. That pregnant woman in Ward 4, that pregnant woman in Ward 4 in Akpatamu, when you get to Agadagba, you'll be on boat for 2.5 hours. What we go to be is his or her fate. That's what we're talking about. And before we came aboard by our grace as a permanent secretary, we look around. And how my sister tell us, when you talk about how many nurses do we have in HMB, he said about. No? I don't know where it's going. He said about 700 FMC, HMB about. Which means there's so robust data. When you ask people, our workers, how many nurses do we have in Ondo State? We say about. How many doctors? About. How many pharmacies? About. How many? About cannot give us anywhere we are. And that's when we came aboard. We have to establish how many health workers we have. Not even how many health workers we have. How many functioning health workers is on ground. We saw in the nominal roles, we have 3 doctors in a place. Of course, one of them is in the UK, practicing any money in Nigeria. And that is why we must know where we are. Of course, the money we pay her, he pay back, 8 million plus. And I told her, I will send you back from Britain by right to the GFC. So immediately he pay back. We must have a robust data of how many workers we have. How do we now make them work? Because we look at central districts, North, Central, and Southern. Majority of our health workers today, they reside in senatorial districts.
Yes, sir. Sorry.
And that is why
Doctor?
when we came aboard, sorry, sir, just give me a second. When we came aboard, we know the data. Then let's come. How do we manage these people we have? And that's why our collaborations with the associations. We call it to the board. We have 30 doctors. All of them reside in Akure. How do we get doctors to other areas? And they help us. Because the era has gone where you just do posting, you transfer a doctor to that place. Don't. Somebody who has built a house in Ore, family in Ore, and you say, go and work in Oka, he won't go. Somebody in Oka, he said, go and work in Ore, he won't go. We even get to that level, go to that level. Where are you residing? Where is your wife? Where are your children schooling? And by God's grace, we have evil distributions of the health workers in those areas today. But I can assure today, all our hospitals, there's none of them that they have health workers. But these are not written. These are all law. These are all where. And that's why you have innovative doctors, the innovative head of the institutions to know what to do part-time. And number 2, the recruitment measure. We are now recruiting workers as we are recruiting, they are going. We look at them. Who are these people that are living per se? How can we encourage them? When we are recruiting nurses, we start recruiting the registered nurses who are still doing their degree. Because they have the degree in front. If we recruit them, we give them a chance to go and complete your degree. In the process of time, they are still be working for us. It's so those who are recruiting today, tomorrow they are already on their way to UK, Australia, Canada, and USA. And these are the strategies we put in place. And moreover, too, we are talking about renovations. There was time we are doing maybe PBF, but nevertheless, there are some little emolument we are giving to them. Majority of them, by all grace, in the hospitals, our accommodation is free.
Thank you.
In the rural areas. And we, by the way, we are just starting. Because we must sow this thing.
Thank you, Doctor.
Wait.
Thank you very much. Our permanent secretary is a grassroots man, very passionate about what he does. A round of applause for him. So please, I would just want to encourage us to stay within the time allotted, which is 2 minutes. And we're still going in the second round, which will be 1 minute, just to put an end to what we are discussing. FA, Akombi, the Permanent Secretary Agency. I would like to ask you, sir, how is the Ondo State Primary Healthcare Development Agency tackling the critical human resource for health gap shortage at the primary health care level, especially in hard-to-reach and rural communities? You have heard some of the challenges that Dr. Adiji mentioned. Please, if it's possible to mention that without repeating what others have said, just give us, thank you.
Thank you, moderator. Let me start by just adding to some of the root causes, because if you don't know where you are coming from, it will be difficult for you to know where you are going. In providing strategies to the huge human resource gap and burden in the country, some of the panelists have identified the issue of remuneration, which is one key factor responsible. Then someone also mentioned the issue of insecurity, which a lot of people usually don't mention. Is a very key factor in driving people out of this country. Then we also have the current economic reality. That is the power of the naira. So even when the remuneration is increased, because in one way or the other, there have been some level of increment in the salary, but is it commensurate with the current economic reality? So
Doctor,
those
sorry, I just want to shed more light.
Yes.
We want you to go straight to what you are doing at the Ondo State Primary Healthcare Board, to tackle this critical situation.
Yes, I try to lay the background. So having said all this, what we are doing as agency, first of all, to improve the issue of remuneration. With the support of the state government, the agency kind of pay advocacy. I think last year, to ensure that the government increased the health workers' remuneration. So, but there is still room for improvement. Because if you want to retain human resources that are living, you don't, it's not enough to bring the remuneration up to the level of your colleague or your counterpart, but you need to raise it probably even above the federal, or even if not at the same level with the federal, above the federal level, so that you can pull people to your system. Then we're also doing what we call the government also, the agency ensure that there is a recruitment based on existing human resource gap. So we leverage on data. That in 2018, staff audit was done at the level of the agency, and then also last year we have the conclusion of the human resource for health in PAC assessment that was done by the Clinton Health Access Initiative. So collaborating with the state government and the agency to identify some gaps, and based on that, we observed that the doctors and nurses were the people that were mostly affected by this brain drain.
Thank you
so
very much.
Based on that, Some months ago, the government gave approval for the employment of nurses and doctors.
Okay,
into
that's the next
system.
thing we'll be discussing. So I would like to cut you there. Thank you very much, sir. So quickly, Dr. Adetumi Shubulade, the Department of from the Department of Community Medicine, Federal Medical Center, Owo. I would like to ask you, how can community-oriented primary health care be leveraged to address human resource, for health shortages, particularly in preventive and promotive health services? Just in 1 minute, sir.
All right, thank you, ma. Thank you, the moderator. I would like to say that we have a very serious issue in our hands, and that's the truth. Primary care, as we know, is actually the initial contact with health care. But the way it is presently, most patients go to the tertiary level, to the secondary level, neglecting the primary health care. Meanwhile, the community-based health care can be a tool to leverage on. There is a policy in 2014 made by the government, because this problem didn't just start today, started years ago. That was task shifting and task sharing policy, and which is a very good one. But it's unfortunate that this, because it's the doctors and nurses that are the worst hit in this matter. We still have CHUs. In fact, we have PACs that CHUs are managed, and we have CHOs as well. These people can actually be trained. We have standing orders in our facilities, and they should also be well monitored. If these persons are well trained in our reason, we are trying to create community advisory boards across so many communities, and one of the feedbacks we'll be getting is actually the situation of PACs. You understand? It's very concerning the health workers. These health workers need to be trained on certain basic things so that they can handle. And not just that, they need to be trained on effective referral, and also very important, monitoring. There's something we call integrated supportive supervision. It's not about traditional supervision that we go and tell people you are not doing it. No, there are ways to monitor people and you ensure they do the right thing. Another point I would like to make before I stop
is actually,
yeah, no problem, is community engagement as well. Community can actually go a long way to help us in the HR gap. Yes, I worked somewhere in Kaduna at a point that the community, good enough, in 2001, the World Health System was created, and which is working well. In that community in Kaduna, in fact, the World Development Committee, they engage pharmacy technicians. They engage some other staff besides the government. So we can't put everything on the government. So these are some of the things that we can leverage on.
Thank you very much, sir. Thank you. A round of applause for all our speakers. So right now, by my own time, I still have 5 more minutes for our speakers to speak by my own time, looking at when we started. But I'm going to go straight to the question and answer session in case we have questions. And please, I would like you to identify who exactly you are directing your question to make it very easy for them to give you a very good answer. Thank you. Please, ushers, can you help me give them? Ushers, should help us pass the mic.
Thank you very much, the panel. You've done a great job. And my question is directed to the CMD of the Unimed Teaching Hospital. I'm so glad to hear that you're paying your house workers very well, and that the state has improved the salaries of doctors and many people working around you. My question is, as they're improving these salaries, are they also making efforts to equip the hospital to a standard that will be able to attract patients and be treated well? Because I have an idea that, I don't know the state now, but maybe last year, there are little or no equipment in the teaching hospital. What is the government making, the efforts they're making to equip this hospital so that they can be effective, not just attracting workers and paying them well, but making them fully engaged properly so that they can administer healthcare to the public? Thank you very much.
Yes, next person. Please make your question very short.
Thank you very much. I am Dr. Ekunda Oluwole. My question is directed to the Permanent Secretary, Hospital Management Board, Dr. Adiji. FMC, as at this moment, the FMC OWO, they boast of large number of doctors, same as University of Medical Sciences here in Ondo. So I think I want to ask, sir, what is the mitigation process? What are the things you are doing to ensure that the doctors within the HMB, that means within the working center of Ondo State, had not been lost to other states? Because I put it to you today, sir, that even Ekiti pays better than Ondo State. Our neighboring Edo State pays better than Ondo State. Nothing stops me as a doctor today to pick up my car and just go to Edo State. So how are you mitigating this within the Hospital Management Board? Thank you very much, sir.
Thank you. Please raise your hand properly so that we can.
Hello, good morning, everyone. Now I'm Dr. Osao Nobewi, and I actually have a question for our Dean of the Faculty of Dentistry, because of his elaborate statistics that he gave concerning gaps. And I also represent one of those that the UNIMED has actually brought back from a JACPA, okay, the other route. So the one thing that I just want to ask is what are we doing to encourage those who have left to come back and to stay? I think that's the major problem, okay, for them to come back and to stay.
Thank you. I think we have two more people.
Good afternoon, everyone. My name is Oligabo Stanfirm from Department of Community Health Science. So my question is directed to the CMD Unimed Teaching Hospital. And I want to thank the Acting Dean Dental Sciences for saying, bringing up on the issue of collaboration on health workers. So my question goes as this. As a community health science student, the community health profession is not recognized, or should I say, clinically, it's not recognized or well known within the profession. So I want to direct this question to the CMD, sir. So what are they are basically clinical skills, or should I say, clinical knowledge that need to be learned from the tertiary, or should I say, state hospital, that can be brought back to the primary health centers in reducing the amount of patients that are being sent to the state hospital. Sir, please, my question is, what is the facilities on ground, or what is the program on ground for the state hospitals to come together and collaborate with professions to teach them about these clinical skills? Thank you, sir.
So we have two more, one and one.
Thank you. My name is Mrs. Yahaya. I'm directing my question to Mrs. Oladipo. When she was explaining the other time, she said that the frontliners are undertrained. So I take that phrase. I want to say, I'm a community health practitioner. I want to say frontliners are not undertrained. As community health practitioner, we have a renewed curriculum. And the problem we are having is that we are underemployed. Thank you.
Thank you. Please, 30 seconds for your question, please.
Thank you. I'm Dr. Adewale, a student, PhD student, Department of Public Health. My first question goes to Mrs. Margaret Oladipupo from College of Health. You mentioned the issue of challenges with infrastructure, lack of lecture theater, and the rest. I know your institution is a tertiary institution, at least to my own understanding. And I don't understand why you don't benefit from the Tetfund. Because I know the Tetfund has been assisting universities, College of Education. So why is it that your institution is not benefiting? So that's my first question. Then my second one is to my friend, Dr. Shubolade. I think on the response to the community-based response to these health worker challenges, is the issue of task shifting, task sharing, is it not working again at the primary healthcare level? And I think that will actually help to us, at least to address some of the challenges in that end. Then my chief, sir, the PS, Minister of Health. Oga, you said that this issue of data, number of nurses that they are mentioning about, I thought you are going to give us the actual number you have, sir. So yes, sir, I'm waiting for that, sir. Thank you, sir.
Thank you very much. Please, last question here, please. Professor MC Azuzu. Prof, 1 minute for your question.
I hope you don't mind my sitting down. I want to make 5 helping comments and ask 2 questions. Number 1, it's been made here. Nursing is the heart of the health professions. You neglect it to your personal and community's ruin. All of us must learn it. Number 2, the problem is not in the health sector. It's a Nigerian matter and human matter. If we address it only here, we are wasting time. The problem is silly partisan politics that creates dehumanizing conditions for living, talk less of working. Nigerians have escaped this country, and they are in Seychelles, they are in Botswana, they are in Fiji Island, and they are earning money. They pay in many of these small countries twice a month, fortnightly, and their salary in a month can pay you in Nigeria for 6 months. Yes. So what are we talking about? There is nothing we can do in the health sector that's going to change that. This country is corrupt to the teeth. 99% of Nigerians, even those abusing government, are ready to compromise the system. So we need a cultural, moral revolution to get out of where we are. Now, in the health sector itself, we have problems. First, in other countries, people are calling auxiliary or intermediary staff, including Nigeria in the colonial days. When you train auxiliary or intermediate staff, you create an avenue for them to climb up the system to the highest level. In Nigeria, the systems we have created for auxiliaries are a dead end. And when they get there to the dead end, they ruin the system. They create systems that empower them with money or clout or whatever and destroy the health system. That's what we're having. The people you call auxiliaries, in Nigeria, I lived there, I don't know how many of you were there. There were grade 3 nurses, grade 2 nurses, grade 1, or stereogyasm, same midwifery. They are medical assistants who become doctors. In other countries, they do the same. But here, we create those auxiliaries and they're dead end. And when they get to the dead end, they will ruin the health system. That's some of the questions I'm hearing here. That's what they're addressing. So until we address that, how do we create systems that allow auxiliaries or intermediary staff who want to become real international professionals to become so? We better decide and deal with it. Then within the health sector itself, the problem you are talking about, data, is a moral problem. You won't have it. Everything has to be fabricated up and down. So only a moral revolution is going to cure it. So please, my two questions are this. How do we create a moral and spiritual revolution in Nigeria to stop the fundamental errors? Anybody who can answer it. I was reading in Edo State, their governor says he's handing over schools, taken over by government by force. That is part of the ruin of our morals in this country. Handing them over. And somebody said, no, they shouldn't hand them over. But people are creating more private schools and there's no law banning them. So why shouldn't you hand over schools you seized from their owners? I mean, does it make sense? That's how Nigeria reasons and works. Now, the auxiliaries we have created, how do we allow so they don't start creating fake professions?
Thank you,
but
Prof.
become professionals, as they do it in other countries. Dr. Michael Okpara, Dr. Samuel, the father of Laird, Imoke, Chris Mbanefo, Chris Okoje.
Thank you,
Professor Ogunlesi, Professor Maboyoje, these were medical assistants. How did they become doctors and professors? By auxiliary training, or what they call bridging programs.
Thank you,
Prof.
Prof.
Become doctors. How did grade 3 nurses, grade 2 nurses become grade 1 nurses? That's what we need to craft. Who answers it? How do we do it? To all the other categories of people we have created in the country.
Thank you very much, Prof. A round of applause for our Prof. Thank you very much. So quickly, we need our panelists to answer this question. Please, we need just 30 seconds, short and concise response to the questions. Those that have been directed to answer the question. Thank you.
The movement of doctors. I can assure today, as we are talking now, for the past 2 years, no more than 3 of people that moved from Ondo State to other states. You may not believe it. Because why? It's all about payment, about the infrastructures, about the prompt payment of salary. In 2010, there's our governor, Mimiko. He did a miracle in the system. When we established teaching hospital, we look at the quotas. Today, they are still living that quotas free of charge. I don't know, maybe somebody is taking money from there. We engineered that. Today, because once you have institutions, availability is the mother of productivity. No matter your skill, once you are not available, it could be useful. How do we make that be available? And that's why we have incentives now. In fact, as at last week, we were still talking about incentive to the health workers, how to reduce their tasks. We will not be able to increase the allowances, but there's a way. We are planning now, but I don't want to reveal the secret to you anyway, it's part of it. There are people today, maybe in the next couple of months now, they'll be tax-free. Some hard-to-reach people, we may give them tax-free. So that it's not that you are increasing salary, but when you are giving them tax-free, you already increase their emolument.
Thank you,
we are
Doctor.
going to reduce the number of the tax too. These are the things we are doing. I want to make them comfortable. Get to some of our hospitals now, we have the solar system, 24 hours light supply. They can charge their phone, do everything. Just like when they come to church, you see them charging phone. Some of them they come to church, come and charge phone. When those lights are available around that place, you make them available. These are the usual things we are doing. And I can tell
Can you answer the second question?
Yeah,
I think about 2 questions were directed to you.
He's looking for data. You see, I have a robust DPRA, Director of Planning and Research and Statistics. I believe in, I have given them the authority. They are the ones that handle data. Every week, they send the data to my phone and to my email and to my own data. For data, if you need it, come and meet me. I will give you the data.
Thank you very much,
But I can assure you, data is ongoing. Thank you very much.
Thank you. Dr. Gbala, please can you answer the question directed?
Thank you, ma'am. Our DVC has asked question about what we're doing about equipment in the hospital. We know that 2 things are very important in having optimum care: the personnel and also the issue of the equipment. when we talk about hospital equipment, there are lightweight equipment and there are heavy-duty equipment. This year, we've made a lot of purchases about the lightweight equipment. The heavy-duty ones, sometimes they have to be customized. As we speak, by the plan we have in place, if you get to the teaching hospital, the issue of the CT scan is being sorted, which has been granted for almost 3 years. In the budget this year, the government is making an effort to purchase MRI. In fact, where the argument is that what government wants to purchase is 3.0 Tesla, which I'm saying no. I don't want us to purchase a 3.0 because the bigger the head, the bigger the headache, that we should actually even come lower. We should settle for 1.5 because the more sophisticated these equipments are, the more difficult it is to get those who will repair. No matter how you maintain the equipment, at the time comes that you need to do that. So if the government is already talking about buying MRI, this is in the neighborhood of almost 2-point-something billion, that shows to you the commitment that we have. One of the challenges is sometimes the citizens don't even trust the government when they say some of these things. But I can tell you as an active player, all these things are being carefully and meticulously implemented. So if government is putting 2-point-something million to buy MRI, then you can be thinking of all the smaller equipment are no longer going to be issue. So I'm asking your question strictly as the manpower is being addressed. A lot of effort is going on.
Thank you, sir.
In addressing the manpower.
Yes, sir. And I think there's another question also directed to you.
Yeah,
Can you just
another
answer
question
that
about what we're doing in giving rooms for the community health people in training. What we've done is to be in
30
talk
seconds, sir.
with the university, what is expected of us. And I've had meetings severally with the head of the department in community health about what they need to do. And we give them a matching directive that all they have the spaces open, whatever they want us to do, that will allow for training, that they have the liberty to do that. Not just that, we keep on urging them to make sure those things are coming in place. And I know in days to come, weeks to come, all those challenges will be sorted out. But if by waiting, things are not sorted out quickly, please feel very free to approach the office and we can also look at things we can sort out in that dimension. Thank you.
Thank you. So we'd like to quickly move to Mrs. Margaret Oladipo to answer questions.
Thank you very much, Mrs. Yahaya. When we talk about the people working in the primary health care, it's not only we community health practitioners. We have other cadres in the health team. And so when I talk about the fact that the frontline health workers are undertrained, unsupported and overburdened, I know what I'm saying. And you cast your mind back to the fact that I said lack of infrastructure. When we talk about the theoretical aspect of the training and we talk about the skill, acquisition. So it's not only enough. Even when we want to talk about the theoretical aspect of the teaching, what we need to use, we can't compare, the teaching, the methodology and everything, the equipment, the infrastructures that we have now in place to what we have in the olden days. Majority of these things, you will see them. The teachers will tell you, these are this and this and this theoretically, but when you get to the field, are you having them? So we don't need to shy away from the truth. So when I say they are undertrained, I'm not saying that we are not using the curriculum to teach our students, but what they need to have, and on-site to have adequate knowledge about what they will need to do when they get to the field, they are not there. That's what I mean. Thank you very much. And for the Tetfund, by the grace of God, it's not a child's play to assess Tetfund, things. We talk about monotechnic, we talk about polytechnic. There are so many prerequisites before a college or an institution will be able to access Tetfund. And by the grace of God, we are working assiduously as a college for that. You have to have MBT accreditation. You have to have, MOU with some of these, agencies before you'll be able to do that. And the college is working very recently. Our provost and the registrar, they were at the MBT board at Abuja, so that when we have all this accreditation, they will be able to access that.
Thank you very much, ma'am. And lastly, Professor Adebayo.
Somebody asked question about what is being done to reverse JAPA and to retain those in the system. Let me start by saying that the university encourages, we cannot stop people from leaving Nigeria. We should forget about stopping people. But what we can do is that we can encourage those that have left to continue to contribute to the system. And so the university continues to encourage those people that still want to make intellectual contributions to the university to apply, and they are given opportunity. Last week, the Federal Minister of Education had a Zoom meeting in which he was discussing the Diaspora Bridge Initiative, in which people who are in the diaspora that want to teach in the universities, visit, give lectures, do demonstrations, they can be facilitated through the federal government. The federal government will pay their airfare, pay their accommodation, but they won't be paid salaries to come and contribute to our health system.
Thank you very much,
To address what Professor Asuzu was talking about, the welfare of the health worker cannot be improved if the welfare of Nigerians is not improved. No matter how much you are paid as salary, no matter what incentives are given to you, when your neighbors or the people around you are poor and broke and wretched,
Prof, 30 seconds, please.
And
so, round up.
And so, the welfare of the health worker is inextricably tied to the welfare and progression and well-being of Nigerians. Secondly, I mentioned that this university has tried to increase the skill sets of some people who previously terminated at HND level. We need to change our culture in terms of accepting the fact that somebody who was a health assistant can become a doctor. The United Kingdom has started a program whereby healthcare workers, various categories of healthcare workers, can go to medical school. They will spend the first 2 years still doing their work, whether they are nurses, they are health attendants,
10
or whatever.
seconds more, Prof.
And the next 3 years, they will come to the medical school and they've graduated the first set. So, various categories of healthcare workers, doctors, pharmacists, we must come to the realization that
Prof, time up, please.
we need to upskill these people so that when they see that there is a hope, when they see there is hope in the future for them, they will not wreck the system the way Professor Suzu has mentioned.
Thank you very much, Prof. And to bring this session to an end, I'm going to give Mrs. Mary Aliu and Dr. Bala just 30 seconds, strictly 30 seconds for their last remark.
Thank you so much. At the ministry level, like the Prof had rightly said, we started the program 2 years ago to train a lower cadre of nurses. And we saw that for them to advance their career, there needs for us to have College of Nursing in Ondo State, because when we started this program, it was when the university came on board that we merged the former School of Nursing to the college. But presently now, the memo is on the table of Mr. Governor that anytime from now, we are starting the middle level of nurses, so to mitigate the shortage that we are having. And we're at the ministry, Doctor mentioned about referral level. We are working on referral level from primary to secondary and tertiary. Those will reduce the bottleneck in transferring of patients. Thank you.
Thank you very much, ma'am. Lastly,
it is not all about complaint or gloom. I think a lot is beginning to shape up for the system with proactive nature. Like it's been said, task shifting sharing will help. Also giving opportunities for career development will be something that is of help, and sometimes also trying to talk to people who can come and give their attention, maybe sometimes not on a full-time basis or locum basis, could also be of help, and also open collaborative for researches that can also help in increasing the funding. These are some of the things that can make the work a bit more lively. Thank you.
Thank you very much. A round of applause to all our speakers. We sincerely appreciate you for coming all the way.
Please don't go yet.
Don't go yet.
Don't go yet. Once again, let's give them a round of applause. We've learned a great deal from them. Now, one major thing that they mentioned in the course of this thing, the word incentive keeps coming up from time to time. And as an institution, we don't just invite people and we allow you to go empty-handed. For us, we want to incentivize you for what you have done, so that when next we call you, you actually heed our call. And to do that for us quickly is no other person than the Deputy Vice Chancellor, ACAD, Professor Rose Angela Nwuba. Please a round of applause for her. As she comes to this side, we have a token for them, and she will present to them. So we have Dr. A.O. Adiji.
Thank you very much, sir, for your contribution to the panel. What for?
Dr. Adetumi Shubulade.
Thank you very much, sir, for your immense contribution to this panel. We appreciate you. Thank you.
Mrs. Aliu Mary.
Thank you very much, ma'am, for your contribution to the panel. We appreciate you, ma'am.
Dr. M. Ogbala.
My CMD, you're welcome. Thank you very much for your contribution to this panel. We appreciate you, sir.
Dr. F.A. Akombiemu.
Thank you very much, sir, for your contribution to this panel. We appreciate you.
Mrs. Margaret Oladipo.
Thank you very much, ma. We appreciate you for your contributions.
Last but not least, Professor E.T. Adebayo.
Our own Dean. Thank you very much for your contribution. We appreciate you. You're welcome, sir.
And please, we want all the panelists to carry the award together, and then we take
photograph.
A quick shot. Please, all the panelists, group photograph. All right, thank you very much. We appreciate you. A round of applause for them. Thank you. Distinguished ladies and gentlemen, while the panel discussion was going on, some of our invited guests also came in. I want to quickly recognize them. I recognize the presence of the keynote speaker for today's event, Dr. Habibu Yahaya, State Coordinator, W Health Organization. You are welcome. We also have Dr. Ibrahim Adebayo, WHO representative, also here. I recognize Dr. D.A. Adewale, health policy expert, University of Ibadan. I recognize Mr. Olamide Ayedun, team lead, Clinton Health Access Initiative, also in our midst this morning. And we have pharmacist Amos Ayegbusi, the executive secretary, Ondo State Drugs and Health Commodities Management Agency, also in our midst. Ladies and gentlemen, what we will do now, you all agree with me that the panel discussion was not just robust, but equally enlightening. It opened our eyes to so many things. And in the course of the discussion, they proffered some critical solutions to the challenge of human resource gap in healthcare sector. And all this will be documented for appropriate implementation. Right now, what we will do is to quickly go to the first panel session. Remember, we skipped it for us to move to the second one. And right now, the moderator for that session is here. Ladies and gentlemen, please let's put our hands together as I bring to this side of the divide Professor Amoron. Professor Amoron is of the Community Medicine Department of the University of Medical Sciences here in Ondo. You are welcome, sir. I believe we can do much better than what we have just done. And our panelists for this session, yes, sir. Our panelists for this session, in no particular order, as I call them, please come to this side of the divide so that we'll set the ball rolling. I invite Dr. A.J. Oyeneyin. Dr. A.J. Oyeneyin is the Director General, Ondo State Contributory Health Commission. Pastor Abiodun Akinseloyin, Permanent Secretary, Ministry of Finance, Ondo State. A round of applause for him. I invite Mr. Olumide Ayedun, Team Lead Chai, Ondo State. Dr. D.A. Adewale is an health policy expert all the way from the University of Ibadan, the premier university. A round of applause for him. Also, I invite Dr. I.O. Aladeniyi, Director of Family Health, Ministry of Health, Ondo State. Stay on his way. Dr. Ibrahim Adebayo, WHO representative, Ondo State. Last but not least is Dr. Akintade. Dr. Akintade is the CMD of the State Specialist Hospital. Yeah, please a round of applause for him. Distinguished ladies and gentlemen, the first session we looked at a critical issue, and this one also is critical. And I know a lot of things that Professor Amoron will lay bare before we begin this discussion. The focus of this discussion is U.S. funding cuts, implication on public health programs. Distinguished ladies and gentlemen, a round of applause for the panelists as they go into the discussion.
Okay, thank you, the MD moderator. I want to welcome everyone to this session, the first panel discussion session. I was told that the session will last for 40 minutes and we have question and answers for 30 minutes. So we welcome all the panelists to this session. I want to start with Dr. Oyeneyin, the Director General Ondo State Contributory Health Commission. We'll be discussing U.S. funding cuts, implication on public health programs. And we are all aware that recently, the new administration in the US, headed by Mr. Trump, had announced cuts and then dissolution of USAID globally, and it has been contracted to a session of the Foreign Affairs Department of the United States. And these have implication because all the US aids that have been given all over the world has been cut to a large extent. And just to give you a background to what brought up this discussion, and that's what we're going to be discussing. How can we get out of this? The resources that are being funded by the USAID, how are they going to be replaced? Is it, and what are we doing as the government of Nigeria and as other collaborating agencies internationally? What are the things that have been set in place to mitigate the effect of this cut? So those are the things that we're going to be discussing and we're going to be hearing. What are the setbacks? What are the challenges? What are the implications of this particular global incident? It came as a hurricane to health funding generally, and many fundings, HIV fundings, many health control programs have been cut. So in this panel, I believe that this panel is made up of eminent personalities, and they will be able to do justice to this topic that we are considering. So I will start with Dr. Oyeneyin. He's the Director General of Ondo State Contributory Health Commission. I want to ask, how might U.S. funding cuts affect the sustainability and expansion of the state-level health insurance scheme, like the Ondo State Contributory Health Commission?
Thank you very much, sir. I will not only dwell on the implication, I will also talk about what the government is doing, both at the national and the subnational level, to mitigate the impact. I think the country is so fortunate that by the National Health Act, state governments were equipped to be able to set up health insurance agencies across the 36 states and FCT for resource mobilization. Without financing to deliver quality healthcare services will be a tall task. And how do we get funding into the health sector? Through budgetary provision, through donor grants, and through health insurance as is experienced in other climes. The budgetary provision, Nigeria signed a pact, Abuja Declaration, that at least 15% of budgetary allocation, either national or subnational, should be minimum 15%. But since that time, we've not been able to achieve that. I think the best we've been able to achieve at the federal level is 5%, and in some state government between 3 to 7%. So the funding cut has grievous implication on the health sector. One, that means there will be reduced funding. Number two, there will be weakened economy because the money that comes in has both direct and indirect effect on the economy. There will be increased healthcare costs. There will be weakened infrastructure. There will be the issue that was discussed earlier on about brain drain is likely going to worsen because of some of these direct and indirect impact. If the infrastructure is not there, the equipments are not there, the support system from donor funding, which account for a major portion of the funding of the health sector, is removed, then it will also worsen. Then there will be potential dropout of those that are under equity scheme, vulnerables that are being provided for by donor grants. What are the solutions? Because somebody mentioned earlier on, we should not dwell too much on what the problems are. We should identify the problem, and we should posit solutions that if we carry it out, then we believe that we can come out of that problem. One of it is to increase revenue. So government needs to do more, improve on budgetary allocation and releases. Thank God the Permanent Secretary, Ministry of Finance is here. We need to have more efficiency and effectiveness in the disbursement of funds in the health sector. People talk about more health for the money. So the little money that we have, we must ensure that we have return on our investment. And we must also cut wastages. About 30 to 40% of spending in the health sector actually go into wastages. We need to increase coverage for the vulnerable group. People that are self-employed can buy health insurance. But what about the pregnant women, children under 5, people with HIV, AIDS, and stuff like that that are hitherto being supported by donor funding? So we need to look for funds to be able to take care of them either through philanthropy, by increasing the Basic Healthcare Provision Fund program, which hitherto was 1% consolidated revenue of the federal government. So we should legislate to review that act to make it minimum 2%, and it must be federal allocation. We must also have what we call community engagement and collaboration. We must take ownership. The other time we were talking about how do we get healthcare workers. I think in some other climes too, communities can come together and recruit. If you recruit and people leave, then they replace. And by doing that, they have ownership. So people cannot migrate. You cannot recruit somebody in Irele and say he wants to go and work in Akure. Then you stop paying him. Then you look for somebody else. So I think necessity is the mother of invention. I think government has been blessed to have resource mobilization across the 36 states and FCT. And we have added about 10 million people under health insurance in the last 4 or 5 years. So if we increase that coverage, we can mobilize more money, and the impact of the funding cut will not have the kind of impact that people were expecting for it to have to crash our health system. Our health system must not crash. We must look for solutions to be able to drive it and ensure that we make it sustainable. Thank you.
Let's put our hands together for Dr. Yahaya. We thank you for the short presentation. I think as we go forward, I think we should have, at least for every participant, for the first round, we should have 4 minutes. And then at the dot of 4 minutes, we should round up and give chance for another, because we are still going to come back the second time. I want to thank you once again. Dr. Yahaya has shed lights on the strategies that is being put in place at the state level to mitigate against these funds and to source for funds, other sources of funding. Well, I will call Pastor Abiodun Akinsheloye, the Permanent Secretary, Ministry of Finance, Ondo State. We want you to educate us about the fiscal measures in Ondo State, the Ondo State government, considering to mitigate the effects of dwindling U.S. health funds on public health programs. So what are the strategies that the state is adopting? What are the recent things that have been put in place for this? Thank you.
Thank you very much. The DG Contributory Pension Agency has mentioned some of the strategies. I want to add that anybody that when you give back to a child, there's a policy that when the child will not live with you forever, at a particular age, the child is supposed to have grown up and be on his own. A good example is at the time we have the Agri Development Agency that is being funded by Agri Development Bank. At the time, the fund ceased, and the onus now was on government to make sure that the program continue. So in the same vein, we should not expect that international donors or partners are going to fund all our projects. Every funding has a timeline, and government has prepared for such eventuality that when such occurs, if the program is germane, that government will continue to fund that project. But the initiative has to come from the managers of the health sector. The budgeting process is such that each agency in the health sector will make presentation. This is our priority area. This is what we need, and this is where funds should be channeled to. Proposals for budget, for appropriation, come from the health sector. So managers in that sector, they have the responsibility to make sure that they bring such to the notice of government. Information has to come to government that we need to appropriate for this, and so on and so forth. Like the contributory pension scheme is like such funding, if the funding is not coming from international agencies, then we should look inward. For example, some of these international partners, donors, not all of them are government agencies. Some are even individuals, private organizations. So, and we have private organizations even in our country. We could also approach them, sensitize them on the need for them as part of their corporate social responsibility to fund the health sector. For example, me and you that are seated here, we're already part of this funding. Because each month from our salary, a certain percentage is taken out that goes to the health sector in form of the insurance scheme. Many of us may not attend your hospital for 6 months, and we are funding it one way or the other. It's like taking money from the privileged to fund the health of the vulnerable group. I'm aware at the time that pregnant women, they have access to free health, and even children from age 1 to 5. So those are part of the areas where government is trying to fill the gap, where the funds from donor agencies are going down. Government is already filling the gap. So the Minister of Health and Office of the Special Advisor on Health has to take up the responsibility to make sure that in social area where we are enjoying, let me put it, might be free fund or free meal, a time will come that this will stop, and that they will have to bring it to the notice of government that we have to start appropriate for it, and the ministry or the regular agency, the health sector, has to bring it to the notice of government on time, that from so and so time, this fund will no longer be coming. And if I want to say that we should not even depend largely on this fund, because I was privileged to be in the cabinet office at the time, and I know that some of this funding we're talking about is not the cash that is coming to us. Most of these intelligence agencies, they are using it to promote their own product. They bring vehicles, they bring all manner of things that may not even be the priority of government. And some of these things are regarded as they are funding the health sectors, whereas most of the time they are using it to sell their product. Products are brought, vehicles are brought, and so on and so forth, that may not even, I don't want to say impact positively on the less privileged in the society. So, left to me alone, the earlier we begin to, jettison this, the better for us. Most of the time, it's not even a grant, it's a loan that we have to pay back. And it's not as if we set our priority right, it's not as if we cannot look inward to solve this problem. Thank you very much.
Let's put our hands together for him. Yeah. Thank you very much. Both Dr. Yahaya and Pastor Akinsheluye has led us to see what the government is doing in mitigating this effect. But let's listen to one of our partners from Chai, the team lead Chai Ondo State, Mr. Olumide Ayedun. We still believe that some of these things will still continue. We want to ask, how is Chai responding to the reduced donor funding in sustaining its technical support to government-led health initiatives in Ondo State?
Okay, thank you very much, the moderator, and thanks a lot to the organizers for, giving us this opportunity to come and, say one or two things regarding this U.S. funding freeze, U.S. funding cut. So I think one thing we must understand here is the fact that initially it was funding freeze, later it's now funding cut, right? So now, as a proactive measure that we took, that's Clinton Health Access Initiative, was first and foremost to understand the impact of this funding freeze and cuts, right? We did an assessment across the 36 states of the Federation to understand the implication of this funding freeze in specific areas that cut across TB treatment, HIV, syphilis, family planning production, services. And, we kind of like understand that these U.S. funding funds actually account for 35 to 40%, of the funding that we are receiving from the U.S. Now, major thing we have to understand is that it's an awakening call for the Nigerian government to wake up to our responsibility. Like Pastor has mentioned earlier, this funding will not, it will not continue as expected. At some point, it will be frozen. At some point, it will be cut short. Now, it is an honor on us for us to look around and begin to think areas of resources mobilization. What are the things we can cut, to actually sustain the health of our people? Are we together? Now, as part of our measures, again, for Clinton Health Access Initiative, is to actually look beyond the fact that, yes, it is the U.S. government that cut this funding. How can we expand or explore other countries, right, to actually help us revive our health, at least for the meantime, right? Because the government of Nigeria is actually not prepared for this cut. But again, as partners, working at the service of the government in collaboration with the Ondo State government, was actually to look out for other donors, within the Western countries, for example, the Global Affairs Canada grant, and some other donor, to see how we can get some funding, right, with the Ondo State government support. Now, what we have done is we have secured a 1-year grant for the Ondo State government. We actually secured that grant for 13 states. And I think it's a laudable achievement for Chai. I think we can appreciate Chai on that basis. So what we did, that grant is going to be launched at the end of July. Now, what we are going to be doing with that grant is a 1-year grant allocated to 13 states in the country. What we are going to achieve with that grant is to actually help provide technical support for the government of Ondo State, specifically Ministry of Health and other key agencies, Primary Care Development Agency, the State Health Insurance Agency, the DMA, to actually see how we can begin to identify some funding gaps, right? How we can provide technical support to begin to cut our expenses and begin to do some level of resource mobilization, so that at the end of the day, by the time we finish this grant, we can help the government to actually see to a large extent how we need to pump some money into the health sector, right? So the grant is actually to propel us and make us see the reality and the implication of this funding cut. So by the end of the 1 year, we expect to see that we are, even if we are not achieving the 15% of the declaration, at least we are moving forward to maybe about 10%. And that is how Chai is coming in this phase. Thank you very much.
Thank you very much. Thank you for, educating us on that. The cut is actually very, very significant, 35 to 40%. And I'm sure many of other agencies will have to devise ways and methods. I wish we have quite a number. We will still talk to WHO on what they are doing to prevent this. Let me turn my attention to Dr. Adewale, who is the health policy expert from University of Ibadan. As an health policy expert, this is a very big and a serious global issue that each country must find a way of filling in the gap. So from a policy and academic perspective, how might U.S. funding cut reshape the health system strengthening agenda in Nigeria? So how do you think it's going to reshape it? You should be able to give us the gaps that we expect, and and that's what the government has responded to. Thank you.
Thank you, the moderator, and I want to thank the people who have actually spoken before me. This development for me is both good and possibly bad. I'm emphasizing that it's actually possibly better for us that there is a cut in funding or loss of support, because the question is, do we really need the funding, the financial support from people outside to start with? And for me, we don't really need it. We are supposed to have have a self-sustenance system. Nigeria has the money, but because of the people who are leading us all along. And when you are talking about policy and policy making, how does it affect us? You want to make policy. When you want to make policy in an air policy or in any policy, there are two factors. It's either that you want to solve a problem that is already happening, or a problem that has not happened, but you have envisaged that in the next few years, 5 years, 10 years, 50 years, from experience, that if nothing is done about it, it will happen. And therefore, you need a policy to prevent such. Now, this one is about something that is already happening. And we have all agreed that is a problem because, to start with, before we make policy, we must agree that this is a problem, something that's not supposed to be a problem for us, like I said the other time. Why should it not be a problem for us? Pastor mentioned something that I'm happy about, and possibly it's not pastor, but someone who has spoken before me mentioned it, that wastages. There are a lot of wastages in the Nigerian health sector. A lot of wastages. For example, one of the problems, on yearly basis, you release a fund, that's the budget. This is what is allocated to the health sector for so year, for this year. Possibly, 3%, 4%, 5% of the total budget. But mind you, the money that will be released, not all that 5%, the value that, that the 5%, tallies with in the total budget will be released to the health sector. They release the money in batches. And I know that the experts are aware about that. It is only when you are done with that and you can account for what you have spent judiciously that next tranche will be released to you. But how is it in Nigeria? It is not so. If it is released to you, then the question now is, what's the capacity of the people to whom the money is released to? To even spend the money. Most of the times, people don't spend that money. They don't. The capacity, money has been given to me to implement some programs. How long will it take me? Or did I make use of that money? If I have not made use of the money, the next batch or the next tranche will not be released to you. So, one, there is not enough fund. We know that the budget is low or lower compared to what was recommended. But of the ones that was even recommended, you don't have the capacity to spend the money to implement projects. How do you expect the government to release the remaining to you? That's a big problem. Again, the second one is about the money that was released to you, transparency, accountability. We all know what is going on. We all know what happens to the money, that is released to different sectors. But we are talking about health sector now. Can we account for the money that was released to us? That's another problem. You don't have enough capacity to spend the money that was released to you. The second is, can you justify the money that was given to you? That's another problem. Then, I've talked about the low capacity for people to spend the money. Now, we now want to make the policy based on that. How do we make policy in the health sector to ensure that the money that was given to us, don't let us talk about poor funding or low funding from the federal government. The one that was given to us, how do we make policy to ensure that that money is actually spent? That is, implement the programs or health interventions that you want to make. That's one policy that needs to be made. Again, what are the policies that will ensure that we are accountable for every kobo that was given to us? That's another one. We all see the stories everywhere. People embezzling money. When you embezzle money, and that money has been allocated to some part of maternal and child health, how do you want to implement that? You cannot. Even if you do, it's going to be a very poor something. We all know that. We have all been engaged in that. Then again, why I said the wastage that pastor or someone else has actually. Now, this is the problem. How do you now solve the problem? As at least some of the problems that have been identified. How do we solve the problem? Forget about poor funding from the federal government. I'm not even talking about that. How do we solve the problem? How do we make use of the money? But what about the wastage? Not in the health sector alone, but even in the general sectors, all the other sectors, including the political sector, people who rule us. And I want to make it bold to say this. We talk about internally generated revenue. How do you look inside that US is not giving us money anymore? What about the ones that you have? What about the allocation to the political sector and those people who are ruling us? What's their salary on monthly basis? We need to start from that. When you have an average worker in Nigeria, I think it's 70 or 77,000 naira now as a minimum wage, is it not? How much does a member of House of Rep, how much do they earn on monthly basis? What about the senators? They earn in millions. And you can see, multiply that for 4 years that they are going to be there. That's where we are supposed to, the IGR, or looking inward, not looking towards Trump now. Looking inward, where we are going to have more money to support our health system. Again, when we stop relying on money coming from the US, they will respect us more. Going beyond the health system, very recently, the visa policy for Nigerians now, for Nigerians, is just 3 months and a single entry. And I'm sure very many people are aware now. But there are some countries that policy is not extended to. They are smaller than Nigeria, but they respect them. They don't go camp in hand, in hand, looking for money. When you keep searching for the so-called money, meanwhile, these people, they are aware about our wealth. They know our money. They know that we are rich. Our people, the politicians, they take our money there and, is it safe or stored in their banks? So they know the billions of naira coming from Nigeria. How would they respect you? And that's why they can just cut it 3 months. It won't stay at that to other sectors. So for me...
Very much. Thank you, Dr. Adewale. One of the things that you have actually emphasized on is curbing wastage in Nigeria health system, policy making, and even the spending itself. Let me now call on, I think I would still love to dwell on that with the Minister of Finance that is amidst us, the Permanent Secretary of Finance, later on when he has the opportunity to talk. Okay. Let me now call on Dr. Akintade. Is the CMD State Specialist Hospital Ondo, in view of all the things that have been discussed, as the CMD of State Specialist Hospital Ondo, how has the recent US funding cuts affect the delivery of donor-funded programs in your hospital? Such programs as HIV/AIDS treatment and services and so on, and several others that are going on in your hospital. How has it affected it? And okay, thank you.
Thank you, Mr. Moderator. The question, because thank you, Mr. Moderator, for that question. Because for every challenge, there is an inherent opportunity. And for me, I don't dwell on challenges. The challenges are there. Like the last speaker has spoken, we should look at the opportunities that has presented for the nation. So now, going to your question, the effect of the funding cut on programs such as the APIN programs in the secondary tertiary healthcare. One is there will be reduced access to healthcare, like maternal and child health care, infection and disease control programs. You know, these ones are going to impact negatively if urgent intervention is not taken. When I mention maternal and child care, already Nigeria has a low maternal mortality, a very bad maternal mortality rating among community of nations. The same way infant mortality rating in Nigeria. So it's going to impact negatively on these factors. Then disease and prevention control, like HIV prevention, tuberculosis and all that, is going to impact on this. And apart from that, the health system financing itself, because there are a lot of ad hoc staff in these programs. So there's likely to be salary cuts or delays for these ad hoc staff who are even collecting peanuts to help patients who are vulnerable or who are down with these illnesses. Then the other issue is the issue of training. When there is funding cut, training of health workers will be affected. There is no doubt about that. So that's in the area of capacity building now. There will be reduced training for health workers. The other one is the disruptions in the programs. There will be disruptions in the program. And this one can affect the supply chain, distributions, and all that. So what are the issues that can be done? Some measures have been provided, but we still have to look for other ways. Because there are so many resources that can be tapped also, apart from what have been mentioned locally. Like, there is alternative financing, like the issue of taxes. A lot of people take alcohol, tobacco. Taxes can be placed on these ones to fund health challenges and to fund health programs. Then the other one is the issue of public-private partnership. These ones can also help to also fund some of these programs. Then there will be innovative financing, like debt for health swaps. If the government can, instead of looking for debt relief, we should look for funding for very good health programs that will enhance the continuity of life for our people. Then the other one is diaspora health bonds. Bonds can be issued out to attract diaspora investments in the health sector. These are other issues that can be done. The regional collaboration among governments in Africa. There are so many things that can be done. We shouldn't be relying on all these Western countries for everything. There is ECOWAS, there are so many groups in Africa. If there are regional collaborations, like the African Center for Disease Control, they have several pillars for, at least there are 3 basic pillars for assessing. Then the other things is leveraging our regional resources. There are a lot of we can do as Africans to actually support our health initiatives and programs. So these are the issues that we should look at critically, apart from what has been said before, like cutting wastages, like being accountable for the money that have been given and all that. So thank you, Mr. Moderator.
Thank you very much, Dr. Akintade. I was reliably informed that we are behind schedule in our time. I will call Dr. Adebayo from WHO in Ondo State to tell us how is WHO helping the government and partners respond to U.S. funding. What are the steps that you have taken in response to this?
Good afternoon, moderator. Good afternoon, every members of the panel, and as well as the audience. Thank you very much for this opportunity to be part of this panel discussion with regards to U.S. aid cuts, the implication on the public health program. I think this is a critical period in global health where you have a disruption with regard to healthcare financing, especially global south, not only in Nigeria, but most importantly in the developing countries of the world. And this USAID cut has actually has a major impact, negative impact on the healthcare development and the healthcare system in developing countries. Let me just, as you know, that WHO is saddled with the task of global health security and also to ensure that the universal health coverage is enforced in every country of the world in order to ensure the utilization and access to good quality healthcare services. This USAID cut is a major challenge to WHO funding structure. Not only to WHO's funding structures, but also to other NGOs, international organizations, and other institutions. When this actually came into being, I think WHO actually have taken a lot of steps, certain steps, systemic in nature, to ensure that the responsibility that WHO is saddled with is maintained. And one of the things that WHO has done is that for us to ensure global health security, which is very, very important, we have to find a way to mobilize resources from other sources and also to advocate high-level advocacy to other countries and other organizations, and as well as individuals, both global and domestic, to ensure that the funding for the health system, especially in developing countries, is maintained, and to make sure that the impact, the kind of disruption that this USAID cut will cause the health system in our country will be very, very minimal, and to ensure the sustainability and the achievement that has been recorded in the global health securities. One of the things that what WHO has done is to do a assessment of the impact of the USA cut. When we look at it, there are a lot of countries that are member countries of WHO, over 190 countries, 183 to be precise. And this country actually have a statutory allocation that they give to WHO. And, but we know among this country, there are a lot of countries that could not actually meet up with their allocation, with their contributions. So that is why we have some group of countries and individuals, organizations, who actually we call major donors, of which USA, some other country in the Western Hemisphere, were actually part. After this assessment, we realized that the major contributions of the USA budget USA budget to the Global Health Security Fund is around 13 to 15%, which is very, very significant if it is cut off like that. And what WHO has done is to do high-level advocacy to countries within the system to ensure that they increase their allocation, their budgetary allocation to WHO in order for us to maintain the global health securities. One. Two, we also ensure that in each country, we mobilize resources locally from organizations, from individuals, like in Nigeria now, there is a foundation called T.Y. Danjuma Foundations, who is actually making a lot of contributions. Also, we also have Bill and Melinda Gates Foundations internationally who has done this. But what WHO now is looking at is paying advocacy, high-level advocacy to the national government, sub-national government, to ensure that they see this as a window of opportunity in policy development, to ensure that they are able to increase their budgetary allocation to healthcare. As we know that WHO standard budgetary allocation is set at 15% of our GDP. And in Nigeria, and we have what we call Abuja declarations that domesticate this particular standard in the country. But since this Abuja declaration, we have not been able to measure up to this. And WHO has gone to the extent of advocating to the government at higher level to ensure that this is done. And after this, WHO is also canvassing to the subnational government to ensure that they increase their allocation of counterpart funding and basket funding to ensure that some of these primary health care programs and all the specific public health programs like emergency preparedness and response, like polio PEP eradication program, like maternal, infant, and child program, like immunization program, that government increase their counterpart funding to this so that at least we can be able to sustain the achievement that we have achieved. As you know that Nigeria has been able to eradicate wild polio virus, and we have been certified free now, but we have circulating variant polio virus in the country, which WHO is mandated to ensure that before the end of this year, we must eradicate this variant polio virus. And this is what WHO has put in place among all other measures that have been put in place to mitigate the impact of this USA cut. Thank you.
Thank you very much. Let's put in all that we have discussed, there are some things that are recurring. That is accountability on the path of the government and those that are managing the resources. Curbing wastage is another issue that has recurred over and over again. And then lastly, the issue of common pause or pulling the funds in a basket to ensure efficiency and efficacy in the management of resources in the health sector. I was told that our time is fast spent. I think we should give chance to the audience to ask questions from the participants. Yes, my brother. Thank you, Abiyamo. So, sorry, please, we jot down the questions, the person that it pertains to, so that we answer together.
Thank you very much, SARS, for the very beautiful discussions. I remain Ekundayo Oluwole. I'm a doctor with Ondo State Contributory Health Commission. Now, my questions goes to the Permanent Secretary, Dr. Adewale and Dr. Akintade, and also Chai. Now, sir, the Permanent Secretary, sir, since the subsidy removal, we all know that the allocation to state governments has increased tremendously. Now, at this point, sir, I want you to just brief us from your own point of view. How many percent increments have we seen in Ondo State's allocation budget to health? Then, Mr. Olamide, thank you very much. I've been working with you for quite a while, and I really do enjoy the support of Clinton Health Access Initiative. You've been doing very well. And I just wanted to ask that, when you do your memorandum of understanding with the government, when you bring your funds, do you always ensure that they bring their counterpart funding before you fund, and also to ensure that there's an understanding between both of you that when you leave, they continue to sustain those things you've been doing with them? Next, to Dr. Adewale, I enjoy you, sir. I think last year in Abeokuta, I was in one of your programs in Abeokuta, and my question, or rather, one of the policy, because you are a very astute policy maker, is that why is it that the government is not looking towards corporate social responsibilities? If today banks, as poor as Nigerians are today, banks are still making profit. They declare profit every day when we see them in the news. In fact, shareholders are enjoying it, they are going home smiling. So why is it that the corporate social responsibility, especially banks, private institutes, nothing costs Wema Bank today to just come to Unimed and donate MRI? So I don't know why that has not been, maybe entrenched in our policy making that private entities should imbibe corporate society social responsibilities into their act every year. Before you declare your profits, you must have given 10% of it as an asset to probably a health institution in your locale. That's another thing that I've been thinking of. Then to my CMD, sir, we are doing very well in SSH Ondo, but my biggest question is this: even if funding is cut, is there no way you can do preventive education by reaching preventive education? If PEPFAR has reduced their funding for HIV program, prevention of maternal to child transmission of HIV, can you not to go to town with your staffs or, incorporate health education into people to prevent these things from even happening? If you reduce the number, you have less amount to spend. That's my own thoughts, sir. Thank you very much.
Thank you. I think we should have other persons asking questions. Yes, my brother. We will take 3 more questions and then we will listen to the response from the panel.
Thank you so much, the panelists. I have a few questions. One to the PS Finance. So how do we match our budget with the current reality? That is the reality of a U.S. funding cut. Because that is the summary of this discussion and where we are supposed to be. Then the second one is to Dr. Adewale. Evidence have shown that there is research to policy gap. And the policy makers are the people in government that implement, even when they invite the academics to participate in policy development and all those things, the implementation and action that policy is supposed to have is at the level of government. So how do we bridge the research to policy gap to ensure that we translate our proposition? I call it proposition now. That is what we find out from our academic research into government action to affect the people, and that is to reduce the gap of this funding cut. Then the third one is to my DG. That's the only DG in the state, in quote. So apology to the other DGs. Is health insurance looking at the area of sink taxes? Because Dr. Akintade mentioned taxing alcohol, cigarette, and all those things. So we target sink taxes to fund health services, especially at this critical period that we are having a donor funding cut. So I don't know whether the health insurance is looking at it. That is not only in Ondo State, at the level of the National Health Insurance Authority, because that is where it will snowball into all the state arms of the insurance agencies. Thank you.
Thank you very much. Yes, my brother there.
Thank you very much, sir. My name is Faki Esoluafemi, and I'm a community health practitioner. And this is my question. Since the U.S. government has cut their funding to Nigeria on some of our healthcare services, why are we not investing in primary healthcare that oppose principle of preventive practices and then the utilization of appropriate technology in addressing these basic healthcare problems? The doctor that spoke first spoke my mind. If we prevent most of these problems, of course, there won't be need for the funding in the first place. People won't get sick if we are able to invest so much in primary healthcare practices that oppose preventives and the utilization of appropriate technology. There's one doctor in Erua, Dr. Awojobi, when he was alive. He's a medical doctor, a facility where he primarily, all what he needs is produced from that facility. One common syringe like this, Dr. Awojobi will not buy from outside. And then that makes his services to be very cheap, that if you go to Awojobi Clinic in Erua during his lifetime, you think you are in UCH because the place is bombarded with patients with getting the product and the commodity that he needs from within his reach. So he's not buying anything from outside. Since this cut has happened, we have seen a lot of things in our facilities, whereby HIV patients that need drugs could not get their drugs, and then we look at what is the way out. So I'm just opining. And then the last thing that I want to say is this gathering that we used to have, and then that we make recommendations and suggestions, what impact does all these recommendations have in policy making process? Are we not just having this for ritual purpose or for the sake of we shall have to gather and do this thing? Thank you very much, sir.
Okay, thank you very much. I think we have enough questions. Let's take those questions because of our time. I will start from Dr. The Permanent Secretary, Ministry of Finance, Pastor Akinsheloyin. We take it, our questions that we have got in that order, so that.
Thank you, Mr. Moderator. My brother from Contributory Health Commission mentioned something about after the removal of subsidy, is there increase in allocation to the health sector? I will say yes. Not only to the health sector, but to every segment of government. There will be increase in terms of monthly releases of running grant and even allocation to programs and projects. If you look at the size of the budget, you will agree with me that is not the same as it were a few years ago before the removal. Of course, yes, the funding from the national government to the subnational government has increased tremendously, and the fund is flowing to the subnational government and also to every sector of the economy. So to your question, I would say yes, there's an increase. But I want to say that we are already in another budget cycle. This is July, and circular has gone out to MDAs to make necessary returns. Very soon, MDAs will be asked to come and present their programs and plans for the coming year. Like I mentioned earlier on, the onus is on the players in the health sector ọmọ tó bá ṣe pa náà máa ń gbé. To, for example, the question is about, I noticed something, to develop resilient domestic financing mechanism. You have to be resilient. The agitation has to come from the health sector. It could start from making, writing memos to Mr. Governor, telling him, intimating him about what is happening in the health sector and how results could be obtained by properly funding the health sector in the face of dwindling funding from development partners and other donor agencies onto the health sector. So information is very key. Memos to Mr. Governor, you have representative in the State Advisory Council. The Special Advisor on Health is there. The Commissioner of Health is there. Somebody asked question about all these talk show, we are doing all this talk show. What is the impact on policies? Yes, this is an academic environment. The product of this discussion could be made, it could be forwarded to the Commissioner for Health to form part of the policy that government can buy into, that can impact positively on the health sector. So, my brother, it is, yes, there's increase in allocation. Then again, there is this another question about how do we match budget with the current realities? Yes. The onus still on the health sector. You have your envelope. Prioritize your activities. Do the necessary things. You don't need to wait until the timing of a program by January, February, or March. It is possible. You can. I've seen it on my table. You can outline all your programs and projects into first quarter, second quarter, third quarter, fourth quarter. These are the things that we need to do. These are the funding that are required to implement them, and justify why those things should be given priority. Once there's a one-off approval for that, it will just be fund will just be released seamlessly for the rest of the year. I've seen it. So the players in the health sector have to be proactive, be resilient, and agitate enough. There should be enough agitation. Then, sorry, sir. Yeah. I just want to add something. The Ministry of Economic Planning and Budget, the players of the health sector has to approach that ministry. Ours, Ministry of Finance, is to release fund appropriated and approved. But there's somebody that does the cooking. The cooking that is at the time of budget preparation. Go there, put all your activities on the table, discuss with the Permanent Secretary of Ministry of Economic Planning and Budget, lay your program before them. The one that the funding are dwindling or be reduced, let them know. And I'm sure that they will solve your problem. In summary, Minister of Finance cannot release any fund that is not appropriated and approved. Thank you very much.
Thank you. Let's put our hands together for him. One of the take-home in this discussion is the fact that the outcome of this conference, I think I'm speaking to the planners now, is we need to disseminate the outcome of these major points and maybe gazette it, and thank God the who is who in the ministry is here, so that we can get it across to the ministries and also at the state level, so that we will have a situation where we have the gown and the town, or how do they call it? So they will meet, and policies and researches that have been cooked in the university could actually be beneficial to the policymakers. So please, plans for dissemination we should actually outline. And he also talked about prioritizing health issues at the ministry level, and those are the important things. I think the rest of us, we have 2 minutes so that we just respond to the questions that have been asked, and then we round up this session because our time is fast spent. Thank you.
Thank you very much. I think I don't think I really have any questions from the audience, but I just want to speak to the impact once again, and to answer the questions partly on the impact of this kind of meeting in policy development. Is it not just a charade where we just come around, see, discuss, have an academic dialogue, and we go our way? In health policy formulation and development, there is what we call preparatory stage, a discussion stage, where the stakeholders come together and identify a problem within the health systems, and they have a discussions around it using evidence from the literatures and from the field to ensure that they put the problem in proper perspective. And one of the key things that is very crucial in health policy development is what we call window of opportunity. And this window of opportunity can come from this level, can also come from what is the current challenge bedeviling the health system, globally or locally. And as we know, that this time around, we have this as a window of opportunity, USAID court, in which this, whatever we agree here, whatever declaration come out of this meeting can be presented at the high level, disseminated to the major stakeholders within the government, and canvass in an advocacy seriously on the need for government to actually increase the budgetary allocation, release the budget as at when due, and let them have the feeling of what is actually going on in the country. I remember recently we have issue with the Lassa Viva challenge, and this when the NCDC, National Rapid Response Team, came to the state, we have to push to the extent of reaching the head of service before this case was presented to the governor, and necessary thing was done. Incident action plan budget that was actually developed to tackle this Lassa Viva outbreak was presented to them, and something was able to be done about it. So I think this is a very good opportunity for us. Thank you very much.
Thank you very much. Over to you, Mr. Olumide.
Yeah, thank you very much for your question, Dr. Ekundayo. I just want to say here again that this workshop is actually a blessing to some of us, and I'm sure we'll all take advantage of it. So in the States, CHI is actually everywhere. We are providing both financial and technical support to key agencies, key MDAs in the States, particularly the State Health Insurance Agency, which is the Ondo State Contributory Commission, the Primary Healthcare Development Agency, and the Ministry of Health. So for us, I can say that we have enjoyed a robust relationship, with the Ondo State government. Most especially till date, CHI has enrolled with the support of the Ondo State government, that's as well as the Ondo State Contributory Commission. We have enrolled a total of 24,255 pregnant women and children under 5 into the health insurance scheme. And these beneficiaries are enjoying monthly capitation. We are paying our capitation, and the Ondo State government is also paying their capitation. And this just shows the fact that the state is really proactive in this regard. They are doing well. They have not for 1 month missed the payment of their capitation. And I think Ondo State government deserves a round of applause. Again, the only reason why CHI can be talking about coming again to provide technical support, concerning this funding freeze, is because we are seeing the fact that government is doing a lot, and we also want to encourage the Ondo State government to do more, right? The funding freeze is actually a blessing for me. It will open our eyes to a lot of opportunities. Just like COVID-19 was a blessing. Before COVID-19, outbreak, we have always been supporting SRMNH, family planning, but with the outbreak and the aftermath, the donors, the partners started looking at health insurance scheme. How can we incorporate vulnerable population of children under 5 and pregnant women, right? So time will not permit me to just go ahead and speak about a lot of the works we are doing. But thank you very much for the opportunity.
Thank you so much. Dr. Mode mentioned the issue of syntax. The summary of everything is we need to get more money for health and more health for the money that we have. For us in the commission, saddled the responsibility of providing health insurance for all residents. We've expanded the frontier now to those in the informal sector to be able to procure their own health insurance plans, which is affordable. For an individual, it's about 18,000, just like 15 naira a day, to have an annual health insurance cover so that you will be protected from the shock of out-of-pocket expenditure. Hardly will anybody go to the hospital now and be able to afford care. And I keep telling people, if you don't have health insurance cover at this time, then you are looking for trouble. We also need to look at the Constitution. Currently, they are reviewing the Constitution in Akure now. I think the Southwest Caucus are meeting, and we should be part of it. There are areas of our Constitution or Health Act that need to be revised to have more funding in health. The National Health Act, I mentioned earlier on, we need to review it. 1% of CRF is no longer enough to cater for large number of the vulnerables. The studies given to the late president indicated that about 78% or 78 million people are under multidimensional poverty level. So we need more money. And how we can go about that in Ondo State, and thank God the PS, Ministry of Finance is here, major stakeholders. What I advocate for, you must have a basket of funds that we can tag the Health Trust Fund. That will cater for the Diaspora Health Fund, cater for resource mobilization from partners, from philanthropies, from political office holders, so that this basket of funds will be managed by a committee and use the funds to address some of these gaps that the funding cut has brought to the fore. I just want to encourage people to take their health as their responsibility. We also continue to appreciate the effort of government. Currently, over 100,000 vulnerable people. More than that, about 130,000 vulnerable people within the state. Pregnant women, children under 5, elderly people, people with disabilities, sickle cell warriors, inmates that don't pay for health insurance that either the federal government or the state government is paying for till date. So I just want to say that the government need to do more. We need to encourage them to do more. And we also need to be more efficient in the expenditure and disbursement of health sector. Thank you.
Thank you very much, Dr. Yahaya. Let's have some word from Dr. Adewale.
Yeah, thank you, the moderator. I'll speak largely on the issue of policy. How do we translate policy into action? That's the gown meeting town, like people say. Well, like people have said, that would this not be another round of just talk, as we have done, all along? Well, for me, 90% of the times is going to be. Why? Because when you want to make policy, making policy is difficult, very, very. But the next phase is policy implementation. If you compare policy making to policy implementation, the energy, the commitment, the sacrifice that you make in implementation of policy is far, far, far ahead and beyond what you need to make the policy. And why is it so? Because you need it, when you are implementing the policy, you need to see it like a private business, like it is mine. when you're implementing policy, possibly on maternal and child health, on this and that, you probably forget to eat. You probably forget, you come back from the field very late. But in government, how many people will do that? People who will do that right now are the people who work with NGOs because they have mandate. They need data for this indicator, for that indicator, and they pay them well anyway. You understand that? Or you could be fired. But when it comes to the government programs, nobody cares. And why? They know that the leaders don't care too. Whether you like it or not, that is just it. You switch on your television, they said President Atioro has gone to England to seek for care. Second day, Professor Igun, the state governor, has gone to Sweden, for his set. They will say it gleefully when they are supposed to be ashamed of it. Then by the time you listen to it, then your wife will tell you, why you want to kill yourself? Even the people that say they are not even here. Okay. You understand that? So you see the level of commitment from the political leaders that is either not there or very low. And therefore, those people who need to implement it, we call them C-level bureaucrats, like nurses, laboratory scientists, and doctors. They are not going to be committed to implementing it. And that's why it's not working. And the only thing that can make it work, like it was in the 60s, is about restructuring of the country. If you don't do it, nothing will work. Thank you.
Okay, thank you very much, Dr. Adewale. Let's listen to Dr. Akintade.
Yeah, thank you, Dr. Ekundayo, for your kind words. Your question borders on going to the community to educate in order to prevent some of these diseases. Well, we have been doing a lot in that direction. If you know, even now, the correctional homes, immigration and all the rest has been removed from the exclusive legislative list into the concurrent list. So as a follow-up to Mr. Governor's his agenda in Ondo State, the State Specialist Hospital Ondo last week was at the correctional home here to educate the inmates, treat their common ailments like cough and all the rest. And we have been going to the markets to also educate the market people on simple preventive measures, and we are still going to do more. Okay. So we are not resting on our oars. Thank you very much.
Thank you very much. With this, we have come to the end of this panel discussion. I want to thank the discussants, Dr. Yeneye, Pastor Akinsheluyin, Mr. Yedun, Dr. Adewale, Dr. Akintade, and Dr. Adebayo for a beautiful presentation. And I believe that all of us have benefited from their wealth of experience. Thank you.
The panelists one more time. And we are going to go beyond just clapping for them like we did for the first set of panelists. But something I observed later on when they had been discussing was that it was an all-man panel. And when when you started mentioning Atioro, Igun, and the rest, those illustrations, you know what was going on my mind when I looked at the 7 of you from there? It was D.O. Fagunwa's Ogbojo that came to my mind. And I asked, why would they be all men? And this Ogbojo and see what they are even be discussing. They've been discussing money. And it is men they will always put out there. Oh yeah, tell us. They've caught this. How do we get money? And somebody said, more money for health, and let's have more health, even for the money that we have at the moment. Sincerely, we appreciate you. You have done well. I said in the morning we had women plus men, and now only men. And you will agree with me that they've done justice to the discussion. If you believe so, and you agree, then do the needful for them. Thank you. We appreciate you. And now we want to concretize the appreciation. Beyond just clapping for you, we have a token also for everybody on this panel. And to present this to all of you is the Dean of the School of Public Health, Dr. Professor Johnson. So the first person here, Dr. A.J. Oyenei.
Thank you very much for all your contribution to the panel.
Dr. D.A. Adewale.
Thank you so much for coming all the way from Ibadan.
Mr. Lamide Ayedu.
Thank you very much for honoring us and all the way, coming all the way.
Thank you. Thank you.
Dr. Ibrahim Adebayo.
Thank you very much. We appreciate you.
Pastor Abiodun Akinsheloyin.
Thank you very much. We appreciate your presence.
Last but not least, Dr. Akintade.
Thank you very much for coming. We appreciate it.
And then please, can we do a group photograph together with your plaque? Ma, you can join them. You can join them. Thank you very much. Please a round of applause for them one more time. Distinguished ladies and gentlemen, we'll move straight to the next item on the agenda. It has been all talk since morning. Right now, there will be some sort of interlude. And let me also announce this to us. The organizers have just told me that those that have been waiting patiently since morning, there's a special gift for all of us at the end of this program. Please do not miss out on the gift. It's not food, it's not material thing, but it's something you are going to cherish for the rest of your life in this side of the divide. I will not say more than that. I won't tell you what the gift is. Just be patient with us. We will soon wrap up the program. Right now, I want to call on Busola Grace, the spoken word artist. Is Busola Grace here? If you are here, please put her. Okay, good. Let's encourage her. A round of applause for her. She has a very short presentation for us. She is a spoken word artist, and she will be taking us through some performance in the next few minutes. Let's encourage her. Let's encourage her. Thank you.
I downloaded something, so I just need the microphone and to play.
Just the microphone.
One for myself and one for the music.
You want somebody to hold that one for you?
No, I'll put it here and.
Maybe it's one off.
Yes, sir.
Can they play it for you
From.
Don't worry.
Alright, sorry. Hello, everyone. Good afternoon. Are we tired? Good afternoon. My name is Busola Grace, and I am so honored to be amongst great minds. Today, I'd like to share a spoken word piece that speaks to the art of our healthcare system, and I've titled, If Walls Could Bleed. If walls could bleed, our clinics would be crimson, not from stitched wounds, but from wear and weakness, from absence of tools, trust, and treatment, from holding up hope on fractured frames. Can you hear it? The heartbeat of a nation. Bam, bam, bam. But listen closely. Sometimes it stutters, not from age, but from absence. Absence of tools, absence of trust, absence of treatment. Once upon a word in Ondo, a woman in labor came pushing through pains. Her contractions were prayers. The powers blinked and the generator stuttered like broken promises. The nurse held her hand and had no gloves. She whispered in Jesus' name, but not from faith, but from lack. How can we measure resilience when a rural clinic's only defibrillator is the heartbeat of its midwife? How? See, we call them health workers, but truly they are hope weavers. Tying threadbare into systems, trying threadbare systems into miracles. Doctors with stethoscopes that doubles as swords. Nurses whose notebooks are filled with murder. The system didn't just break in a day. It bruised slowly. The way malaria creeps in when the net has a tear. It bruised the day the ambulance became museum decor. When oxygen became rare, so rare and even rarer than rainfall in February. It bruised when hospitals became houses of waiting with no end in sight. It bruised the day a boy bled at the back of a bus because the hospital was too far and faith was faster than the ambulance. Please help me. Help me. Please help me, sir. Please help me. Please, I beg of you. That's my only son. That's my only son. Please, I'm desperately begging. Please, I beg you. Please, just take a look at him. Please, he has been there for the past 3 hours and he's bleeding. I just need help. Please, just one look at him. Please, I beg. Please, I beg, please, just one look at him. That's my only son. Please help me. Madam, I understand. I totally understand. I do. Honestly, I do. See, we've tried all our possible best. We have oxygen, but what good is availability if it is void of accessibility? What essence is to bank on our health system if we've got to break a bank? What good is it? See, health is not a privilege, it's a promise. Not padded by pedigree, but protected by purpose.
Get new
yes,
DJ
it
mixes
is.
every day on
That's what it is. We need to stop placing plasters on problems and calling it policy. We need systems. We need systems and not just saviors. We need frameworks and not just flashlights in the dark. We need to build. We need to build. We need to build not just facilities, but ferocities. We need to build not just clinics, but character. Not just medicine, but meaning. We need to build. Let not our investment not end in inventory, but also in impact. Let us train not just heads, but hearts. Let us train not just as staff, but as soul of service. Let's budget for breath, for birth, for better. Because when pandemics come, they don't knock. They barge in with full force. And when they barge in, they come in barefaced and bold. And only a house built on rock with rafters of readiness and built of equity will stand. To the doctors, your degrees are divine calling. To policymakers, your pens are scalpels, carefully written with care. To the students, please don't flee. Be the best you can be. Be the floodgates. Yes, be it. Stay. Stay so the system doesn't sway. This is a resilience prescription. 1 dose of vision, 2 tablets of will, 3 injections of courage, 4 referrals to courage. Repeat daily. Yes, that it is. I hope we are running on the right path. The human right path. The path that does not just build and invest in education, but in the path that does not just build and invest in medication, but invest in education and the right to sensitization and stigmatization. The right path that invests not just in inclusion, but in health care, in the love that we share. Invest in a future where we can collectively play our part, a future that begins with me and you, a future where we can collectively join the queue to save a life or two, a future that begins with me and you. So let's build systems that will not just stand but speak. Let's build systems. For every faint pulse we couldn't save, may we rise to save the next. May we rise to rescue the next. So let us build walls. Let us build systems so our walls will never have to bleed again. Thank you.
Thank you for clapping for her. Thank you. That was an awesome performance. I described your performance as awesome because it was a total performance. She brought in emotion into it. Not just emotion, she laid bare some of the challenges the panelists have raised here today. And she also mentioned what is critical for all of us to do. That in spite of all these challenges, in spite of the shortcomings, it is not ghosts that will solve these problems. It is us. There is a collective responsibility. And she specifically mentioned people, critical stakeholders in the area. This is a case of art meeting with science, and she did it very well. Once again, let's give her a round of applause. Thank you. Thank you. Thank you. I'm counting. Some people left. They won't get the gift. They've already handed over the gift to me. And now time for us to make progress. Now there's something innovative about what we've been doing here today. And you ask me why. We faced some challenges at the beginning, certain logistic challenges, but we've been going on, and we can connect everything and they will still make sense. There has been disruption in a way. We were supposed to start the technical session with keynote address, but I see that it's becoming like a blessing for us in disguise. Second panel came before the first one, and the first one talked about the gaps that we have, particularly in human resources. And then I said, even when we have the human resources, we need money. God has been orchestrating the plan, now taking the money to the second. But in all of these, we have suspended everything, the superstructure in the air, because the structure must be laid. We still need to listen to our keynoter, who has something important also to tell us. And it is only those that wait till the end that will get the gift. They've brought them, and they are here with me. Distinguished ladies and gentlemen, with the permission of the Deputy Vice Chancellor Akkad, may I please crave the indulgence of our keynoter to come to the podium and remain standing while I read his citation to us. Please, a round of applause for our keynoter. Our keynoter's name is Dr. Habibu Yahaya. Dr. Habibu Yahaya is the World Health Organization State Coordinator for Ondo State. He is recognized for his distinguished service and impactful contributions to global public health across diverse and challenging contexts. A highly accomplished public health professional, Dr. Yahaya holds an MBBS from University of Ilorin in 1995, a Master of Public Health at Ahmadu Bello University, Zaria, 2001, and a PhD in Public Health from the University of the Western Cape, South Africa, 2021. Over the course of his career, he has served in key technical and leadership roles within the World Health Organization, the United States Agency for International Development, and ICAP at Columbia University, supported by U.S. Centers for Disease Control and Prevention. Dr. Yahaya's work has spanned both national and international settings, including Nigeria, Rewa district in Madhya Pradesh, India, and the Somali region of Ethiopia. His leadership in health systems strengthening, disease surveillance, immunization, emergency response, and maternal and child health has significantly improved health outcomes in underserved and high-risk populations. Known for his strategic vision, technical excellence, and deep commitment to health equity, Dr. Yahaya has consistently delivered high-impact results across humanitarian and development settings. His multidisciplinary expertise and dedication to capacity building have left a legacy In the institutions and communities he has served, Dr. Habibu Yahaya embodies the principles of integrity, service, and excellence in public health, and continues to inspire the next generation of global health leaders. Distinguished ladies and gentlemen, I present our keynoter for today to you, Dr. Habibu Yahaya.
Well, thank you very much, the moderator, the Deputy Vice Chancellor, the numerous professors that are here present, my DG for the contributory health insurance. Thank you. Okay. Other partners here present, distinguished ladies and gentlemen, and of course, the students and our leaders for tomorrow. Now, we are just going to discuss the health system strengthening issue. And now we are focusing on building resilience for the future. Now, my time, even though I don't know my time, but what I want to say is that before I get into the topic, the panelists that have spoken actually have paved way and made my own presentation much simpler. Again, the last artist that made the simulations also supported what I am here to present. I could remember about 30 years ago when I was a house officer in a very high volume health facility. I will not mention the state, but what I experienced, made me to start regretting why did I even become a medical doctor. Because my posting was in obstetrics and gynecology. And that night, what I made, I was faced with serious problems, which are basically what? Health system weaknesses that I faced that night. And in the event, I missed 8 pregnant women that were before me, crying and asking me, "Oh, doctor, please help me." I couldn't help any of them. Why? Because of the health system issues that were evident in that health facility. 5 of them died of postpartum hemorrhage. All we needed was what? Blood bag and some component of blood donors and what have you. The husband came, he had the donors. However, the money to buy the blood bag was not there. And the money to do cross-matching and screening for HIV and what have you. So all the husband could bring out was 20 naira when we were looking for 500 naira. And that was how we missed, all the 5 postpartum hemorrhage cases to death. Again, the 3 of them that died, they died of what? Obstructed labor. And that obstructed labor, all we needed, we were there, doctors, to operate and provide cesarean section. But there was no cesarean section pack. Because of that reason, we lost these individuals to death. That is what? That is health systems for you. Now, so, as a background, public health faced growing threats, of course, from pandemics, conflicts, climate change. Weak health system lead to service disruption, preventable death, and poor outcomes. WHO supports countries to build what we call resilient people-centered system that withstand shocks and deliver results. Now, what is the existing problem for and what necessitated, this workshop? We need to have a resilient health system. WHO Health System Performance Assessment ranked Nigeria at 187 among the 191 countries. Okay. And this highlights what? The failure of our own health system. Inadequate health infrastructure, poor service integration, a shortage of human resource for health, and health system instability is evident in this, our country. Health system fragility resulted globally in about 1.2 billion, within Nigeria, it resulted in about $1.2 billion loss from the Nigerian economy to medical tourism yearly. Again, Nigerian health system faced acute shocks, of course, from epidemics, outbreaks of lesser fever, outbreaks of cholera, outbreaks of measles, spinal meningitis, and indeed from pandemics. We were all witnesses of what happened during the COVID era, and of course, other chronic stressors. Here we are talking about policy issues, health system issues, issues that have to do with funding of our health system, and then persistent strikes by health workers. Now let's go into the topic, which is what? Which is resilient. Now resilience is part of the goal of World Health Organization Health System Strengthening Agenda. Of course, within the agenda, we have 4-pronged strategies. One of them is sustainable health system, an equitable health system, an efficient health system, and indeed a health system that is what? That is resilient. And all these 3 strategies will give you rise to what? To universal health coverage. Now, what is the concept of resilience? If we say a health system should be resilient, what does it mean? This is a word that came in, or a strategy that gained interest, particularly, during the era of COVID-19. The concept and application of resilience emerged as a critical priority from the COVID era. And resilience refers to the health system's capacity, at least in the context of my presentations. We have several, definitions for resilience. But for the context of my presentation, we should see resilience in the health system as the capacity of the health system to absorb shocks, adapt the dynamics of health, and transform. Resilience, I want to draw our attention to the fact that resilience is not what? Synonymous with strong health systems. Why? Because a health system can be strong in a stable condition, but becomes susceptible to shocks of pandemic or other issues that can affect it. It can be resilient but underperforming. So you can have a suboptimal health system, but with resilience built into it. And then resilience, therefore, is necessary for the functioning of a health system. But resilience alone is not sufficient. Now, because of time, I cannot take us back into stories. But I would like to tell you that exactly 20 years ago, we were the individuals, then I was working with the USAID. We brought in interventions against what? Against the HIV/AIDS pandemic in Nigeria in those days. USAID saw the plight, of patients in those times. And what was happening, we were using then as doctors a medicine we call Triamul, which has lamivudine, efavirenz, and what have you. That medication used to cost 50,000 naira a month. So patients will go, they will buy the medication this month, and the other month they will go and start, harnessing money to buy for the next shot. So there are a lot of missing of medications that. And most of those patients that we had, most of them, they died due to resistant strains of HIV. Now we came in, we faced a very weak health system. The doctors, the nurses that were there, even the CHUs, we were looking for people that will give what? That will manage patients in terms of ART treatments, in terms of HIV counseling and testing, in terms of drug adherence, in terms of laboratory capacity. All those things were not there then. So what did the US government did? They bring in money. They bring in technology. They brought in what? Drugs. So we recruited our doctors. We recruited our counselors. And we injected them into the health facilities. The US government brought laboratory equipment, the vitros machine for chemistry, fast count I could remember, for hematology. Before we use, our patients have to stay in a queue for 1 month before they get their chemistry results out. And once these machines were introduced, within minutes, people got their own outcome of their own results. The CD4 count machine was there, and we started, it was excellent. And by the time we enroll our own patients, all the medications were there. The first line ART were there, adequate for our own patients. And then drugs for opportunistic infections were also there. And that is how we started. And we continued till when it was like 2011. We started in 2005. When it was 2011, then the US government decided to start shifting the responsibility to the host government. And there was jittery across board, including us that were paid by these donors, and particularly the patients, especially those that were on treatment. And that is how it started. And that generated my topic for my PhD, which was what? The effects of devolution of ART treatment program from donors to local ownership. And I can tell you my thesis attracted a lot of global interest. I got a lot of grants, the Africa Doctoral Research Fellowship, the University of Cape Town, University of Western Cape, after I presented my proposal. Why? Because the topic is really what? Very, very sensitive. Now, we have said what resilience refers to. So what are those things that we need to ensure resilience. These are all that we needed to ensure a resilient health system. Integrated service delivery and primary health care approach, the human resource development, HMIS, which is Health Management Information System, digital innovation, health care financing for sustainability, governance, leadership and accountability, emergency preparedness and response to outbreaks and health security in general, and then community engagement and equity. And last but not the least, health system research and operational research. These put together will give you what? A resilient health system. Now, we started taking these individual thematic areas one by one. So quickly, what is an integrated service delivery and primary healthcare framework? We should have a primary health care under the primary health care revitalization. The Nigerian health system is doing well as far as we are concerned. Why? By trying as much as possible to build into the existing WHO rapid response advice. Now, Nigeria had implemented the PHC revitalization in such a way that there is at least one primary health care per ward. The second thing is to promote integration of services. Here we are talking about reproductive, maternal, child, adolescent health, its own integration with even our non-communicable diseases. Hypertension, diabetes mellitus, all these degenerative diseases, cancers. So, under integration of services, we look at different services put together in such a way that a patient can have various services at one service point. And lastly, under this, we need to strengthen the primary health care infrastructure and workforce. And Nigerian system is doing well. Currently, WHO is spearheading what we call the TSTS, which is task shifting and task sharing. And this phenomenon came in when we were implementing the HIV response. Because we realized that the doctors that were there were grossly inadequate to manage our own patients. So how do we now transform a nurse or even a CHU to do the work of a medical doctor to some extent? And that brought about the issue of task shifting and task sharing. And then a team-based care model. I was in a teaching hospital. During our own time in Ilorin there, you have, the nurses and doctors, they work together when they are doing, ward round, grand rounds. Everybody was going together and with the same spirit. But what I saw last 2-3 years, made me to weep. Because I saw in a teaching hospital, doctors were going on grand round. The nurses were not there. When I now asked, where are the nurses? They said the nurses are not following doctors because of the friction between them. So what is happening? The nurses were there. They will just go after the doctors have finished all making their own prescriptions, and they will go and take those bedhead tickets and start providing the nursing services. And that is detrimental to the health system, detrimental to the patients. Again, the issue of referral and supervision are very, very critical. You are doing task shifting, But there is no way a nurse can become a medical doctor. No way a Jew can become a nurse or a medical doctor. We are mindful of that. So once you reach your own limit, you need to refer your patient. The health workforce, a lot of discussion has been done on this. And one individual had made a point. How do we make sure that we are just not here to blow rhetorics? We just say things, and where is the action? The policy makers, I can see only one or two. The DG is here. However, where is the governor? Where is the deputy governor? Where are the commissioners? And the health is a multi-sectoral, ministry that requires everybody to come on deck. So, since they are not here, what do we need to do? We need to carry on what? Advocacy to the Vice Chancellor if we have issues within the university regarding health. In the teaching hospital, the CMD is there so that we implement what we are proposing here. Now, WHO estimates a projected shortfall of 18 million health workers by 2030 globally. Health workers are the critical pathway to obtaining the health target in Sustainable Development Goals number 3. Chronic underinvestment in education and training of health workers in Nigeria is evident. There is also a mismatch between education and employment strategies in relation to the health system needs and the population needs. Time will not permit me to go into all these things, explanation for all these things. But there is also difficulties in deploying health workers to rural areas, remote and underserved areas. And globally, not only in Nigeria, about 45% of all humanity live in our rural areas. In Nigeria, it's much, much higher than that. However, people don't want to go to remote places. So what is the recommendation here? Deployment should focus on underserved populations, training on surveillance, health emergency response, and non-communicable diseases and service integration. We need to build in this training within our own health facilities. It has been started in the primary health sector. But what about the huge, big health facilities, our secondary institutions, and particularly the tertiary institutions? Motivation and retention strategies. Doctors in thousands, they are leaving the country because of poor wages. So the government need to invest. I had someone saying that doctors and health workers cannot be treated in isolation. That once the population is poor, they should also be part of that music. I tend to differ with that because in so doing, Nigeria is losing a lot from brain drain of doctors and renowned teachers in our own tertiary institutions. So the issue of motivation and retention can be emphasized through advocacy also. In-service mentorship of the existing workforce. Our own trainings as doctors stops once we leave the medical school. The same thing with nurses and other paramedics. So we need to extend training and mentorship to this class outside the school environment. Now there is what we call the data and digital transformation of the health system. Here we refer to the use of reliable, robust data which plays an integral role in public health planning.
It's going to be very brief. It's an address by pharmacist. I want to call on pharmacist Amos Ayeguse to do his presentation. I was told that he would do it for 10 minutes. He's from Ondo State Drugs and Health Commodities Management Agency, the general manager, so that you should know that he's a big man that I'm bringing to this side. Please a round of applause for him. The presentation is supposed to be for 10 minutes, but he has told me that whatever I want to tell you in 10 minutes, I can do in 5 minutes. And I will do it in a way all of you will be able to relate with. And I know him to be a man of his words. A round of applause for Pharmacist Amos.
Thank you very much. Let me not just waste our time because of the time has been well spent. Let me also appreciate the Vice Chancellor, member of the top table, and our keynote address speaker. That speech I'm so marvelous about it, and I want to thank you for that contribution. Let me just go quickly to, during the COVID era, we found out that we don't have a sustainable drug distribution system. Our system failed us. Like I said, we have a system that cannot shocks. The changes in the dollar exchange rate actually slap us in the back and the face that we don't have a sustainable drug distribution system. What we have was very chaotic, and that brings in manipulations into the system to the extent that we have so many substandard drugs in our health systems. So at the National Council on Health 2021, it was agreed that we must have a sustainable